Got it? All right. I don't have a video feed. And we have a video feed. Okay. We are live. All right. Good morning, guys.
Good morning.
How is everybody today? This is Wednesday of week 2, which marks the halfway point of your program. Goes fast. Goes very fast. Before we get started, somebody had emailed me yesterday, and or this morning, I guess it was, and I just wanted to read this out. It says, "Good morning, checking in from New York. Did my exam yesterday and passed. Your videos helped a lot. So congratulations. Good job, Saria Juliet. Good job. All right. So over between the last class and today, you had chapter 4 to read in your book. So you should have read that chapter in the yellow book and taken the test here on page 184 of your white book and then graded it using the answer key on page 201. When I call your name, either let me know how many you got wrong or your grade. Sheila. Thank you. Jaden. Thank you. Ariana. Audrey. Ethan.
85.
Thank you. Ashley. That's fine. Emily. Mercedes. Martina.
100.
Thank you. Susie. Amanda. Brittany.
100.
Madison. Rain.
85.
Thank you. Thank you. And Olivia. You can get caught up. That's fine. I'm just adding you on here, so I don't forget to ask. All right. Any questions before we get started? Anything that you missed on the homework and don't know why you missed it? You don't know why the right answer is the right answer? Anything you need me to explain? We're going to review chapter 4 before we get started. Chapter 4 was all on the body systems. There's 10 major body systems in the body. And we kind of have to understand that all of these body systems work together to keep us healthy. If something's wrong in one body system, it's going to affect other body systems somehow. So it's kind of like, think of it as a busy city, right? You have to have mail delivery, but you also have to have trash pickup. If you don't have one or the other, your life is going to be impacted. And then if there's a traffic accident somewhere that clogs up the roads, stops traffic, that's going to affect everything. So different conditions are going to affect different body systems, but because those body systems are intertwined, you can have what we call cascading effects. Does that make sense? So this is why it's so important as a CNA that we report everything. Whether we think it means something or not is completely immaterial. Doesn't matter, because you don't know if that symptom is tied to something that's going on with the patient. So everything that we notice, we report. But in order to kind of figure this out, we have to know what normal signs of aging are. What's normal? Now, we already talked a little bit about this last class. We learned about the disintegration of the fat layer between the skin and the muscle and how that can affect your patient's temperature perception. It can do a lot of other things too, but we've learned that there is a change of aging. But the skin isn't the only thing that changes when we age. Basically, everything is going to be affected. So I'm going to take you through these 10 body systems, and we're going to briefly touch on some of the normal changes that come with aging. Because in order to know abnormal, we have to learn normal. Make sense? All right. So the first one we're going to start with is the nervous system. Go ahead, Jake. And the nervous system is made up of the brain, the spinal cords, the nerves. This is our control center of the body. This controls everything. Something goes wrong here, you're probably going to feel it pretty much everywhere because the nervous system is what controls. So your food can't be digested properly without input from the brain. Just can't. Your lungs won't breathe properly without input from the brain. Your muscles won't work right without input from the brain. So this brain just, it controls absolutely everything. So when we have some issues with the brain, it tends to affect our entire body. As we age, this brain ages too. And my favorite analogy to use for this is related to dementia, because a lot of us think about dementia when we think about old people. But not all memory loss is dementia. And let me explain what I mean by that. If I were to invent something, let me just invent this pen. It's quick and easy and right here. So if I were to invent something, okay, and I wanted to have it produced and I need a factory to make this thing for me, I'm going to go tour some factories. And the first factory that I tour is brand new, state of the art, totally computerized. Everything works fantastic. There's no downtime, and it always produces a high quality thing. Sounds like a good factory, right? It's brand new. Second factory I go look at is 80 years old. The gears are rusted. It's old technology. It's falling apart, and it's not going to produce pens all the time. And when it does, not all of them are going to be good. Which factory do I want? Why?
Because it has good quality.
Quality, right? It's all about the quality and the efficiency. We all want the new factory. Well, your brain is a factory. Your brain is a memory making factory. That's one of the things your brain does. So when you are brand new, your factory is brand new, and it is going to produce high quality, consistently accurate memories. It's good because your brain making, or your memory making factory, the brain, is new. But once that memory making factory gets to be 80 years old, the memories you're making with that factory aren't going to be as good because the quality isn't there. Your brain is rusted and broken down and may not be working today. And this is why a lot of our older patients have no idea if they had lunch today, but they can remember the shoes they wore to a piano recital when they were 12. It's because the memories that the 12-year-old brain made are good quality. They're going to stick around for a very long time. But the memory of that 80-year-old brain that made from lunch wasn't all that memorable. That brain, that memory factory, just isn't working well right now. So it's not making memories. That inability to recall recent events consistently, that's not dementia. That's actually just the aging process. So short-term memory impairment, things like, where did I put my keys? Where did I park my car? Did I eat today? Did I take my pills? Those types of things, very, very common as we age. Who are you again? With a family member, that's not normal. Okay, does that make sense?
Yes.
Now, this is way more pronounced when we develop dementia, specifically. And over the weekend, you're going to be reading chapter 5, which is going to talk to you about dementia. Dementia is just a very general term. It just means sick brain. Doesn't give us specifics. But when your patient has dementia, this is going to be even more pronounced. because with dementia, those earlier memories are accessed by current memories for reference. Okay. So this is why somebody who's 80 years old can look at their grandchild and know who their grandchild is. But an 80-year-old with dementia may look at the grandchild and think it's their child because you've got that association of events. And if you don't have anything newer to associate with, your first memory might be of your child when they were that age. So this is pretty common with dementia. We have to understand that patients that have short-term memory loss or memory impairment or dementia are going to need a lot more emotional support because this can be scary. This can be frightening if you can't recall things. Good? Does that make sense? There's some other changes that are going to happen beyond memories with our brain as it ages. Our senses are going to decrease in effectiveness. So where you may be able to see just fine as young people, your eyes are working very well. As you age, those eyes probably aren't going to work as well. And you may not be able to see fine details. And this might make it hard for you to tie your shoes because you just can't see those fine details, or button your clothes, or get those peas to stay on your spoon, right? Fine details might be affected. I remember when I was in high school, I used to write microscopic. I mean, I literally would try to get my letters just as small as I could. Just micro. I had good eyes back then. And I remember my teachers going, no, you got to rewrite this because I cannot read that at all. Rewrite it. And after rewriting several papers, I kind of learned that these are old eyes. They're not, they're not on my wavelength. I've got to play their game. So I wrote a little bit bigger. Now, my now person wants to go back and slap that high school version of me. So this happens whether you want it to or not. Okay. Hearing is going to be affected a lot of times with our older individuals. They may not be able to hear properly, but hearing is one of those things that's really interesting because hearing actually happens in two parts. There's the physical act of hearing, and that's going to be affected because the little structures inside your eardrum get stiffer. They don't oscillate as well. So the physical act of hearing is affected, but what's also affected is the processing. When you hear something physically, it goes into your eardrums and it goes to your brain. Your brain has to be able to decode those vibration patterns into speech, into something your brain can use. Now that's called processing. And processing is affected as we age. And you can have an older person that is constantly going, huh? What? Can you say that again? What? And you start to say it again, and then they answer, and you're like, why did you ask me to repeat it if you heard what I said the first time? Give them a second. When you say something and they say, huh, or what, give it a second because it may take some time for the brain to decode what you actually said, and then they can answer you. But if you jump right in and you start saying it again, you can scramble those signals. So when it comes to communicating with older people, slow down. We tend to go really fast because that's how we do things. You're not dealing with your age ears and brain. Slow down. Give them a second. Let them process what you just said. And then if they're still like, what? Then you can repeat it. But don't shout. Because remember I said there's two parts of this. There's the physical hearing, and then there's the processing part. Well, the physical hearing is affected. And when you have somebody that has some hearing loss, you don't want to shout at them because when you shout, your voice goes higher in octave. And higher pitch is harder to hear. So the best thing you can do is take a step closer and lower your pitch. So closer and lower. Good. Make sure you face them, because a lot of people will watch your facial expressions. They'll actually read your lips for context. So make sure you're facing them and the lighting is good. Shouting at somebody does not help. Does not help. So if you get a test question on the state exam, this is a very common test question. You're working with a client who can't seem to hear what you're saying. What do you do? Shouting at them, never the right answer, ever. Don't pick that one. Okay. Decreased coordination. This is very common. This leads to a lot of falls. Our muscles don't react to our brain impulses the same way. Balance can be off. We can get some slower reflexes, memory impairment we've talked about, decreased concentration. This is less relevant now than it was 10 years ago, and it's because of you guys. Everybody right now is suffering from decreased concentration, so you won't pick this up on your patients. Right now, you have the attention span of a goldfish. Seriously. How many of you guys are on social media in any capacity? Yeah, absolutely. When you flip through social media, and social media is now predominantly video-based, right? We don't read text anymore. 5 years ago, you were reading texts. You were reading posts. You don't do that anymore. You go straight to Reels. You go straight to TikToks. You're consuming content in a video format because your attention span has decreased. You don't have the patience to read anymore. You did this. This is cultural. Can you imagine in 5 years what we're going to be like then? If this happened in 5 years, imagine what the next 5 years are going to bring. Right now, you have the attention span of a goldfish. 5 years from now, you'll probably have the attention span of an eyelash. I mean, it's real. This is real. Now, let me kind of prove it to you. You're already in an evolutionary arc. You just don't know it. So, right, we're all consuming video-based content, right? Well, 3 years ago, you were watching that entire video. How many of you guys actually watched the entire video before flipping to the next one? Or do you just kind of watch 2 or 3 seconds and scroll on? You don't even have enough brain power to watch a 10-second video. This is why I'm saying you have the attention span of a goldfish. You don't even watch a 10-second video anymore. So we went from digesting text-based to going to video, and now we don't even watch the whole video. We watch a few seconds, and then we flip to the next one. I am frightened, truly frightened to see where we're going to be in 5 years. Scary. You're not going to notice your patients decrease in concentration because you don't have concentration right now either, so it's okay. Go ahead. All right, cardiovascular system made up of the heart, the blood vessels. We have talked about this in our last class. We talked about it on class 2 as well with pulse. So you know a little bit about the heart and how it works. As we age, that muscle doesn't work so well anymore. It's not going to pump as hard, and it probably isn't going to pump as often because it's tired. Your heart has pumped on average 70 times a minute, every minute for your entire life. It never took a coffee break. It never sat down and put its feet up. It never went on vacation. It has done its job consistently now for 80 years. You think it's tired? So your heart isn't going to be as effective. And if it's not as effective, it's not going to push blood around effectively. Remember, we need that contraction of the heart to push that wave out. That wave pushes the one in front of it. That one pushes the one in front of it, right? Well, if our heart is now going, we're not going to get good wave action here. And that can affect every part of us because our blood vessels feed every part of us. It can lead to decreased endurance. You just can't do as much as you used to. You tire out easier. Higher blood pressures. We're going to talk about that a little more today. Prolonged bleeding and fragile vein walls. Very, very common. For nurses, those of you who go on for nursing, this right here is going to be the bane of your existence. Because when you learn how to do IVs, they will blow on you. You put an IV in, you get it secured, and the next thing you know, the IV's gone. And you're, just so frustrated because fragile vein walls is a thing. It is a real thing. It's a lack of collagen and elasticity that make up the integrity of those veins. And we have to make sure that we're taking the steps that we can to ensure the integrity of our vascular system when we're working with patients. The other thing, because this is an issue, if you're working in an acute care setting with IVs, you need to be reporting anything you see with that IV site: redness, swelling, discoloration, anything. If you notice it, what do we have to do with it? Report it, because IVs do blow, and we don't want all the stuff that we're putting into the IV to go into the tissues. That's bad news.
So is it an IV, like the medicine in the bottle, you give the patients what kind of medicine they have, they must take, and then they have to put a needle in
Right.
skin?
Right. That's an IV.
And the pipe has to go to, the medicine has to go through the pipe and go through to your blood vessels, right?
Right. Right. That's an IV. Intravenous.
Okay.
That's what IV stands for, into the vein. Go ahead, Jake. Next one is respiratory. Cardio and respiratory work together. Cardio pushes the blood around. Respiratory puts that oxygen in the blood so the body can use it. Takes away carbon dioxide. Like every other system in the body, this one's going to age. It's not going to work as well. You're going to get decreased lung volume. They just can't expand their lungs as much. Encouraging your patient to deep breathe is a really good thing to do, because that just keeps that bottom of the lungs a little more pliant. Decreased endurance, especially with exertion, walking. So where you can walk to the bathroom just fine and there's no issue there at all, your patient might be out of breath by the time they get to the bathroom, and you're like, it was like 10 feet. What is wrong with you? Well, what's wrong with them is that their lung volume has decreased. They're not expanding the bottom of their lungs. So instead of having an entire lung to breathe with, they now only have this much of their lung to breathe with. It's not going to be enough air. So they're going to get short of breath with exertion. Shortness of breath, very common. These are all things we need to report to the nurse, though. We're going to see them, but we still report them to the nurse, especially if they appear worse. Go ahead. Endocrine system. This is kind of one of those unknown body systems we really don't think too much about. Like, we all know about the heart. We all know about the lungs. We all know about the brain. I mean, those are easy ones. The endocrine system's a little more complex and a little more lesser known. But your endocrine system is your master. Nothing can run without endocrine glands. Nothing in your body. Your endocrine glands are the ones that produce hormones. Now, your hormones are messengers that go throughout your body. So you have a thyroid hormone. When I say the word hormone, we all immediately go to sex hormones, because that's what we're used to thinking of. Sex hormones is just one of a bazillion hormones that you have in your body. Pituitary, thyroid, adrenal, your pancreas produces insulin, which is a hormone. There's a million hormones in your body. It regulates everything from blood pressure to temperature to digestion processes to how well your muscles work. Hormones are important. And unfortunately, this system is going to age like every other system in the body, and we're going to get some natural decreases in function. So decrease in hormone production, which is going to cause sleep disruptions, decreased bone density. Have you ever heard the term osteoporosis? Okay, osteoporosis means that the body is mining calcium out of the bones. Now, why would the body do that? Well, the main reason is that cardiac system, that heart. Your heart beats because of a shift between calcium and potassium in the cell. So calcium goes in, potassium comes out, action happens, potassium goes back in, calcium comes back out, another action happens. So your heart actually has to have a very delicate balance of calcium and potassium. If we don't have enough calcium in our bloodstream, your body has to go find it. Where do you think we store calcium at? In the bones. So your body actually puts on a little hard hat, grabs pickaxe, and just starts chipping away at some bones to put calcium into the system. Yeah. And that can reduce the integrity of the bones. So if our patients who we know have weakness and instability and, a propensity to fall. So if they do fall, what could happen here with a decreased bone density? That's right. You're going to break bones. Yeah. So reduced metabolic rate's very common too. We just don't burn calories as efficiently as we used to. Do you remember what when we talked about burning calories? It was to generate heat to keep our temperature up in the normal range. You guys remember that? Okay. Well, if we have a reduced if we're not burning food as efficiently, what do you think that's going to do to our core temperature?
It goes down.
That's right. So our older individuals will also often have a lower body temperature, what we call a basal temperature. Good. Go ahead. Urinary, that's another body system. This is one we're all familiar with. Our urinary system lets us know it's there every day. Changes of aging for this one is going to be a decreased bladder capacity. It's just not going to hold as much. You young people, you amaze me. My best friend, she just aggravates the crap out of me sometimes. I love her to death, but I used to take a lot of road trips with her. And she has the bladder of a camel. Like, we would get in her vehicle and go. After like 5 hours, I'm like, can we find a bathroom, please? And she's like, no, I'm good. I'm like, I'm not. I mean, she can last for like 12 hours and not have to pee, right? I've never had that kind of bladder capacity ever. But this, as we get older, is going to degrade. You're just not going to be able to hold as much because that bladder, the fibers of the bladder, they're stretchy. They stretch as urine gets in there, right? Well, elastic over time. Have you ever had a rubber band that you just stretch and stretch and stretch and stretch? It gets floppy, right? Doesn't stretch well anymore. It never bounces back where it was supposed to be. That's exactly what's happening with the bladder. It's nothing more than it's made up of a whole bunch of rubber bands that have been overstretched for too long. When we go to the bathroom, that rubber band is going to kind of compress to get whatever urine is in there out. Well, if our rubber bands are floppy, if our bladder muscle is floppy, we're not going to get complete emptying. Does that make sense? And we also have decreased muscle control in controlling that urine stream. So what does this mean? It means your patient is going to have to pee a lot. A lot. So you're going to take them to the bathroom, and an hour later, they're going to go, excuse me, can you help me go to the bathroom? And you're going to be like, you just went. Yeah, but I got to go again. And if you don't take them to the bathroom, we have decreased muscle tone. You think that urine's going to wait for it to be convenient for you? No. So now, because of us, your patient is suffering from a little bit of stress incontinence, right? That urine's going to leak out. And they're going to get all kinds of embarrassed because that's not fair, right? So a big part of what CNAs are going to do is help patients with toileting. And this has to be done promptly. This is a dignity issue. Does that make sense? Okay, go ahead. We also have the integumentary system. We've talked about this. We already know most of these. Thinner, drier skin, brittle nails, decrease in subcutaneous fat. We've talked about all of those in the skills that we've covered so far. We also get changes in hair color. Yeah, I'm demonstrating that. I'm like way overdue for my hair. Yeah, I look at it this way. It's kind of like the body saying, okay, we don't have enough resources for everything, so let's cut off hair production. Let's just turn that off. We're shuttle that energy over to like keeping the heart beating, right? So hair tends to lose color. In exchange for that, we get color deposits in places that we never had them before. So it's like it takes the color that should be on the hair and just throws it onto the skin randomly. Here you go. So we end up with dark spots, aging spots. Like I'd like to have a little conversation with, the master control center here. Set it straight. Go ahead. Reproductive, this kind of goes without saying. You have a decrease in reproductive capability on both sexes. With women, because of menopause, it pretty much shuts off reproductive capability as far as childbearing. Men can still father children throughout their lifespan, but the frequency is probably going to be a bit reduced. But they still retain the ability. Women stop producing or stop releasing eggs in menopause. So all of these hormone disruptions in the reproductive system can cause hot flashes and night sweats. It can cause decreased moisture production and erectile dysfunction. It can cause some irritation in external skin. This is going to become important to us when we start talking about pericare next week. If we don't have our natural moisture, we've got to make sure that when we're doing pericare, we're keeping that in mind and we're being very, very gentle. Decreased fertility also is going to be a byproduct of this. Go ahead. Gastrointestinal. This is the stomach, the intestines, all of the different organs that are associated with digesting food and burning calories. So we want to extract the nutrients and we want to make sure that we're generating heat. When we age, digestion is going to slow down. Now, the number one thing you're going to see with this is that you, when you're younger, may be used to eating a big meal late at night or, later in the evening. And then you're fine. You can go to bed and there's no problem with that because you're young and your systems are all working fine. But as we age and our systems start to become affected, this is where you're going to see it the most. Older patients often cannot eat big meals late at night. Their bigger meal is going to be earlier in the day because their digestion slows down. It is always best if your patient is able to ambulate or walk, to walk them to the dining room, no matter how slow that process is, and to walk them back, because that action actually helps with the digestion process. A lot of CNAs get this wrong. They just want to get all of their patients to the dining room as quickly as possible and get those trays passed. So they'll put patients in wheelchairs that don't need to be in wheelchairs and wheel them to the dining room just to get it done. Well, if your patient's digestion has already slowed down and there's no activity, this can cause a lot of really bad complications for your patient. So activity is going to be a huge part of this. It's what's going to help digestion be maintained. They'll also probably get fuller faster. Now, I'm actually seeing this with my mom. She used to eat just, a normal plate of food. Now, when she's eating, she's only eating about half of her plate and putting it in the refrigerator for later or for tomorrow. So I'm actually seeing this in real time with my mom. Sad, scary. I don't like it. I don't like seeing my mom age. So I'm trying to think of what can I do to help her with some of these changes of aging to make it more comfortable with her based on what I know. Decrease in esophagus tone is a huge one. A lot of your patients are going to have problems swallowing. They're going to cough a lot. They're not going to be able to eat hard, crunchy foods. So soft tacos, not crunchy ones. Constipation, very, very common, and that's because everything is slowed down. Turns to concrete. We don't absorb nutrients as well as we used to, and we have decreased hunger and thirst reflex. This is the big one though, thirst. Decreased. When you get thirsty, that's your body's way of saying, hey, take a drink. We're a little low on fluids, please. It's kind of like the add gas light coming on in your car, right? There's something there that reminds you, hey, you need fluid. And we go take a drink and life goes on and we don't even think about it. The problem is that as we get older, that gas light never comes on. Just doesn't come on. And unless you're looking at your gas gauge, you could miss this and run out of fluid. We call this dehydration. And it is very, very common in older people because their gas light never comes on. So when we're working with older people, it is a really, really good idea to encourage them to drink every time you walk in the room. Every time. Did you take a drink yet? You want some water? How about a sip? Take a sip for me. Chrissy says, good morning, Miss Patty. I passed my exam, both theory and clinical, on my first time, all because of your videos. Thank you for what you do. Congratulations, Chrissy. Great job. Oh, I'm super proud. All right, so make sure that you're monitoring your patient's fluid intake. You're going to be the one that notices this because you're the one in the room. Go ahead. Musculoskeletal system. This is bones, muscles, tendons, ligaments, cartilage. I have a lot of problems in this area already. Can't wait to see what age is going to do to me. We have decreased bone density, reduction in muscle mass. We don't have the same tone or elasticity that we did. Decreased strength. And then you get the problem children, the inflammation of joints. We call this arthritis. Arthritis. This leads to pain and stiffness, instability and coordination issues. In short, your patients that are older are always a fall risk, always. When you put the nervous system that controls it with the musculoskeletal system, and both of those have aged, falls become very common, very common. So we want to try to prevent falls whenever possible. Look around for obstacles. Go ahead. Lymphatic system. This is the new kid on the block. We never used to really talk about the lymph system very much, but it is, I would say, as important as the cardiovascular system, right? The cardiovascular system pushes blood to every area of your body so it gets good blood flow, good oxygen, can keep working. Well, your lymph system takes all the bad stuff away. Takes extra fluid and filters it, puts it back in circulation. It maintains fluid balance. It helps fight infections. This is a super important body system. And of course, it's not going to work well as we age, which leaves us open to infections. This reduces our ability to fight infections. It can also result in swelling, and swollen, swelling of the tissues and swollen lymph nodes as they don't work properly. They get clogged up. All right. So that was a review of chapter 4. Did that help you guys at all? You will have a few questions on the state exam about normal signs of aging, about how body systems work. But they're not going to be straightforward questions. They're not going to be like the cardiovascular system is made up of A, B, C, D. That's not the type of questions they're going to ask you because that's not really in the scope of practice of a CNA. They're going to put it into a scenario form and see if you can recognize an abnormality. So you have to know what I just went over so you can recognize abnormalities. Okay, good. All right, so we learned how to take a pulse. We're going to review these really quickly. A pulse is a measurement of how many times the heartbeat over 1 minute. We're going to support the arm. We're going to follow the care plan as to how long we're going to count. Normal is between 60 and 100, and we don't use our thumb to take a pulse. We use the tips of our fingers, not the flat part. The pulse is located at the top of the thumb side of the wrist, way up here at the bendy part. We put the thumb on the back to hold consistent pressure. This is a documentation skill, so you have to make sure you document. In Florida, you will count with both evaluators if they're both there. Okay? Dressing a resident, we're going to ask them what they want to wear. We're going to get clothing before we undress them. We're going to maximize privacy and minimize exposure using the curtain, the blanket, and choosing their clothes before we get them undressed. Anything that we have to lift, we lift from below with the flat palm supporting at the joints. We undress the strong arm first and dress the weak arm first. We don't overextend or force movement. We adjust clothing for neatness and appearance, and anything we took off of the bed or the patient goes into dirty linen, not on the floor. Nothing goes on the floor. Call light goes in the stronger hand. Go ahead. Hand and nail care. We follow the care plan. We're going to support the wrist and arm at all times as we move it in and out of the basin, and we're going to soak the hand in water, take it out, and put it on a towel to wash it. Put it back in the basin to rinse, take it out, and put it on a towel to dry it. We're going to use an orange stick, slanted end, bevel up to clean under the nails, wiping it off between each nail. File the nails in one direction toward the center, and then apply lotion. Remember, when you apply lotion, you warm it up and you wipe it off. Okay. Making an occupied bed. Clean rolls toward me. Dirty rolls away. Yep. Patient will be on their side in the middle of the bed when you change that bottom sheet, because we have to change it a half at a time. So we're going to take that dirty sheet, roll it toward the patient, put the clean sheet on, roll it toward us, and tuck it under the dirty. Get the patient back on their back in the middle of the bed, go around to the other side, repeat the process. Put the top sheet on, secure it under the mattress using hospital corners. Basically, guys, make sure that the corners aren't touching the floor. That's what they're looking for here. Replace the pillowcase with the opening facing away from the door. Limit the amount of time without that pillow. And make sure at the end of the skill, they are on the center of the bed with a sheet covering them and a pillow under their head. Make sure they look good. Helen says, how many body systems are we supposed to know? Because some places I see 11 or 12. I don't know if I'm the one who is confused. Yeah, it depends on the source, Helen. You know, as far as some people break body systems down into more granular. There's nothing on the state exam that asks you how many body systems there are. That's not a CNA. That's more of a teaching issue. That's not a CNA thing. So no, nobody's going to ask you how many body systems there are. Okay. Yeah, if you ask Google, I mean, Google will give you pretty much any answer. By the way, guys, you do know that everything on the internet is not necessarily written by an expert. You guys know that, right?
Yeah.
So if you're looking up, and this is a big one. I actually talked about this on my last game show. This is a big one. I used AI to write some questions this last time. I wanted to see what kind of questions AI would give me for CNA questions. And so I typed it into AI and I got a list of questions back. And out of the 20 questions I asked it to make for me, only 4 were correct. Only 4. Now, unfortunately, you've got a lot of companies out there that make a very good living by putting questions on websites, getting you to go to that website, and they make money off of ads that they show you while you're doing these questions. They don't care if the questions are right or not. They're not writing these. Who do you think is writing these questions? AI. That's right. And they don't care if they're right. In fact, it's even better for them if they're wrong. Because if they're wrong, it just drives me nuts, guys. This is a soapbox issue for me. If they're wrong, if those questions are wrong, you assume they're right when you take them, right? So I'll give you just a very general example. What color is the sky? Blue, right? So you pick blue. And the answer is actually gray. And you're like, but Well, yeah, it's gray when it's raining, but it says it's the right answer. There must be something I don't know. So you keep taking these tests because you think there's knowledge there that you don't know. And that keeps you on the website longer, which means they can show you more ads and make more.
Money.
So it benefits them to have questions on there that you are absolutely going to fail. That's scary. They don't care about you. They care about the money that site is making them. So you know that all content on the internet is not true. So when you see things like that, take it with a grain of salt. Okay. You can go ahead and advance, Jake. Yeah, sorry about that. All right, we learned how to do range of motion. Remember that CNAs do range of motion to retain, not regain. We're not trying to make anything better. We're going to lift extremities with a flat palm, supporting at both joints. We'll move slowly and smoothly, returning all the way to the start position. Follow your care plan. Exercise what they tell you to exercise, how they tell you to exercise it, and how many repetitions. You just follow the care plan. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around and not on the test. We don't rotate on the test. Go ahead. Look at everything you've learned. Good job. Good job. Any questions on review? Okay, we're going to jump into today. All right, our first skill today is side lying position. Side lying position. We're going to turn a patient over onto their side and use some pillows to keep them there. Where should the patient be when they're on their side in the bed? In the middle. Why? Can't I use side rails to keep them in the middle?
No,
Why?
because it's unsafe and can lead the patient to tightness and when they turn to get out of bed.
Right, right. It's not safe. But remember that side rails require what do they require? A doctor's order. So we can't make that determination. So we're going to turn a patient over onto their side and use some pillows to keep them there. That means we have to scoot them toward us first before we roll them. Now I'm going to show you that this skill is all about learning how to position somebody so you can roll them easy. I can roll somebody about 3 times my body weight with no stress on me or them. I don't need a second person. It's all about learning the right process. Okay. Does that make sense? Way back in my career, I used to work with morbidly obese patients that were waiting to get surgery to help reduce their body mass. And I would see them for about 4 or 5 months before they went into surgery. And these are mainly people that are bed bound. They're, well over 500 pounds. They can't support their own weight anymore. So I would have to go in and turn them and clean them and, put different lotions on for skin issues that they had and, that type of thing. So I can turn somebody 3 times my body weight with no issues at all. It's learning how to set it up to make it easy. And that's what the skill really is all about. If you just go over to a patient who's laying in a bed like this and you just try to roll them and manhandle, they're going to be all over the place and they're probably going to fall off because you're not equal in where you're applying the pressure. Okay. So learning how to do this will help you tremendously in your career. If you look down the side, you can see all the principles involved. They're all spelled out for us here. Not much that we have to learn. We are going to cover a little more of scoot and roll today, but we know skill rules, the opening, glove rules, barrier, privacy blanket, linen rules, and the closing. Not much there to learn. And we know most of skill rules. We're just going to cover a little bit more today in depth. This skill should take somebody with your level of experience about 8 minutes to do. It's going to be done on another live testing student. That person will be laying in bed at the beginning of the skill. Documentation is not required. Now, for this skill, if you get this skill, They're going to try to pair you up with somebody your body size or smaller. They're not going to take a 90-pound individual and throw a 300-pound person in the bed for the test. Test is minimum competency levels. That means that they have to find the easiest way to set the test up for you, not the hardest. And when you start to realize that, you'll see that there's nothing tricky about this test. They're not trying to trick you. So they're going to try to find somebody your body size or smaller. Go ahead, Jake. So if you look on page 139, the top of the page has our care plan. Step-by-step instructions are located there for you. And the bottom of the page has supplies listed. This one is easy. We need a barrier on the table. We need a bath blanket to cover, and we need 3 pillows to hold them in place. This is an easy supply skill. Go ahead. Let's take a look at the care plan. It says position the resident on his left side. Which side?
Left side.
What if it said right? Then you put him on the right. I don't know what the care plan for the test is going to say. It could say left, could say right. What are we going to do?
Follow the care
Follow the care plan. Absolutely. Patient requires support to remain on his side and is unable to assist with turning. Does this say the patient is immobile?
No.
Does it say they're paralyzed?
No.
So don't make them. This is the number one error that is done on this skill. People read this care plan and assume that because the patient can't roll, they must be paralyzed. They must not be able to do anything on their own. And that is not what this care plan says. Remember, we follow the care plan, the whole care plan, and don't add to it. Says they can't roll. Doesn't mean they can't scoot toward us. Says they can't roll. So when you're trying to picture a patient for this, I want you to think of a younger person that just had abdominal surgery and they cut straight down the middle of the abdomen. They can't flip over. Their abdomen isn't put back together right now. They can scoot though. They can wiggle their butt over. They just can't roll. Got it? Okay, go ahead, Jake. So we know pretty much everything we need to know for this. We're going to talk about skill specific now. A brief reminder on restraints. Remember that side rails are considered a restraint, just like a crib with a child. Once a baby starts to crawl out of the crib, we can't leave them there. We have to take them out. Same thing with side rails. An adult will climb over these side rails no matter what you say. You're not going to stop them from climbing over side rails if they want to get up. So I'll give you a great example of this. Knowing what we know, what we learned about chapter 4, we have a patient in bed and we were concerned that they're a fall risk because they're older and their coordination is decreased. And we know that if they fall, they're probably likely to break something because they're older, right? Those are all really good reasons to keep them from walking on their own, aren't they? So we put the patient in bed, put side rails up to keep them there because we don't want that patient up roaming around, putting themselves in danger. So we put side rails up. Patient hits call light. I got to pee. You're in the middle of something. I'll be there in a minute. We make them wait. How long can they wait? Not long. They hit the call light again. I really have to pee. You're like, I'll be there in a minute. I'm busy right now. Give me a second. They wait a little longer. Now they're in trouble. They're either going to wet the bed or they're going to get up out of the bed and get themselves to the bathroom. If they were home and you weren't there, what would they do? They would get up. They would get up. The only thing keeping them from getting up is that side rail and you. You really think they care about you? No, they are not going to want to wet themselves. So they're going to get up. We've put an obstacle in their way. Did we really ensure this patient's safety? No, we actually gave them something else to put them in danger. This is why side rails cannot be used without a doctor's order. Good? Joe says, hello, Miss Patty. I passed my clinical skills and written exam because of your lectures and videos. I want to say thank you so much for your teaching for free. God bless you. Congratulations. Thank you. Thank you so much for the blessings. I love what I do. All right, go ahead, Jake. All right, so remember, positioning rails are not side rails. They're just there to help the patient move about in bed. But let's talk about immobile patients. I told you this patient is not immobile. Our care plan doesn't say they're immobile. We're not going to think about them as immobile, but I do want to talk about immobile. What does it mean? What does it mean for us as caregivers? If somebody is truly immobile, if they cannot move on their own, we have to do everything for them. If somebody can't move, are they going to be able to brush their own teeth?
No.
If they can't move, are they going to be able to feed themselves?
No.
If they can't move, are they going to be able to wipe their own butt?
No.
So somebody that's immobile needs everything, all care. We call this a total care individual. Okay, go ahead. But there's something else when we have a total care individual, an immobile individual, that we have to talk about, and that's their skin. Skin is really compromised when your patient is immobile. And I'm going to do a demonstration right here to help you understand just how quickly this can happen and how serious it can get. One of the biggest organs that's affected with immobility is the skin. Go ahead, Jake. So while I'm talking right now, I want you to take one hand and put it underneath your leg. I want you to sit on a hand. I'm going to ask you not to move this hand for 2 minutes, please. And it's going to get uncomfortable. You're going to want to pull it out. Just please bear with me. This demonstration works a whole lot better if you play along. Okay? So 2 minutes. Go ahead, Jake. All right. So when we are laying down, gravity is pulling us to the center of the earth. If we didn't have gravity, this wouldn't be an issue. But we have gravity. It's how it keeps us all on earth. Otherwise, we'd all float away. So this gravity is pulling everything down. When you're laying down, that means your whole body weight is being pulled down to the center of the earth. Well, what's between the middle of your body and the surface you're laying on, right? There's bones. There's bones. There's muscles. There's fat layers, and there's skin. So there's a whole lot of things that are being pulled down. And all of those bones, where they get close to the skin, these are called pressure points. This is the maximum effort that's exerted by gravity on the body. So the back of the head, the shoulders, the elbows, the lower back or coccyx area, the back of the thighs, back of the calves, and the heels, these are all what we call pressure areas, where gravity is pulling down on these areas, and there's bones that are going to smush the content underneath. Go ahead. So if we kind of did a cutaway, this is what it would look like. You have a bone that's going to squish the muscle, the fat, and the skin between the bone and the surface you're laying on. What this does, we've got some blood vessels here. What it does, all that pressure is going to squish those blood vessels closed. Go ahead. So if we have pressure coming down from above that's smushing those blood vessels, and we have pressure pushing up from below because of wrinkles or foreign objects, what's caught in the middle is this skin. And the problem is that skin is not getting good blood flow because those blood vessels are squished shut. And what does this mean? Go ahead. If we have pressure from above and pressure from below and no good blood flow, those cells in that area are going to die. They're going to die. Go ahead. Go ahead and pull your hands out. I want you to look closely at your hand. Do you see color changes?
Yes.
Look really closely. Can you see the pattern of your clothes or the chair imprinted?
Yes.
Guys, that was 2 minutes. 2 minutes, and you already have lines and color changes. 2 minutes. And you are healthy. You're healthy. So can you imagine for a second? Go ahead. Go ahead. Can you imagine for a second if we left somebody that couldn't move on their own in the same position for a very long time? Now, if you got red marks and creases in 2 minutes, understand that those red marks are going to get redder the longer you leave the hand there. Those creases are going to get deeper the longer you leave the hand there. And over time, because we don't have good blood flow to the area, we squish down our blood vessels. Over time, that's going to cause those dead cells to give away. And we end up with skin openings. The skin actually cracks open because those skin cells just quit holding on to one another. They're dead. They can't hold on to anything. And that is called a pressure sore. Good. So this affects everybody, whether you're immobile or not. I mean, it just affected you guys. You got red skin. You got, pressure areas just in 2 minutes. This affects everybody. But for us, you and I, we're able to move. So when we're in bed at night and we go to sleep, we don't wake up in the exact same position. You toss and turn all night long. And the reason you toss and turn is because of this. Your body says, hey, we need some blood flow to that left hip. Could you move, please? And you flip over. A little while later, your brain is going to tell your leg, hey, we need to relieve that pressure on that right knee. Stretch it. So your leg stretches out. This is a little piece of your brain that's always awake, always on. That little piece of the brain will constantly reposition you to allow blood flow to these areas and prevent that area from dying. So you are constantly shifting your position. You're doing it in this chairs right now. You jiggle your leg, you cross your legs one over the other, you sit forward, you sit back, you kind of shift from one butt cheek to the other. You're always moving. You are not sitting completely still. And that's good because that allows blood to move to all of these areas. That's a good thing. But what if we weren't able to do that? What if we couldn't shift our position on our own? We would need somebody to do that for us. Understanding why we're doing it. It's for blood flow and circulation. Does that make sense? Okay, go ahead. So patients that can't move on their own have to be turned at least every 2 hours. Guys, 2 minutes is all it took for your hand to get red. 2 hours, that's like the very outside edge of what we can get away with. 2 hours. A lot of my patients, when I was working in hospice, my care plans, we reposition them every hour to help prevent bed sores. Remember, 2 hours is the outside amount of time. Where I get into problems with CNAs is your compassion. You will look at this patient and I've got to reposition that patient every 2 hours around the clock. And that really means around the clock, guys. We're waking them up at 2 a.m., at 4 a.m., at 6 a.m., at 8 a.m. We're not letting them sleep all night. We're waking them up every 2 hours and flipping them over and changing their position. And your compassion will say to you, oh, I don't want to wake Fred up. Let's let him sleep through the night tonight. I told you 2 hours was the outside amount of time. The very max amount of time we can leave this person without turning them before they get skin issues. Did you do Fred any favors? No, because when you wake Fred up the next morning, he's going to have a pressure sore. And we're going to be trying to heal that for the next 2 years. And this is horrifically painful. Horrifically. In one night, I have seen a bed sore occur that went all the way to the bone. In one night. The next morning, when I flipped the patient over, I was looking at bone. Went to the CNA. What happened? Oh, well, I felt bad waking him up. I just let him sleep all night. That was not in the care plan. Nowhere in that care plan told you to think. You follow instructions. Because now this guy is going to die. And that's exactly what happened. He did not have the immune ability to fight off this wound, and it killed him. This is no joke, guys. The things we do can have a long-term effect on your patients. CNAs kill just as many patients as surgeons every year by not following the care plan, because you're making decisions without complete information. Does that make sense? I can't stress this enough. Don't kill your patients. We have to turn them every 2 hours around the clock. That's the maximum amount of time we can wait. Good? Now, yeah, go back real quick. Now, when we're talking about this, you can actually make these. CNAs can make these and put them up on the wall. This is called a turning clock. I love these things. I make them when I was in clinical practice. I did this all the time. I always had a turning clock on the wall because as the nurse, when I walk in that room, it is what? What time is it? It is 10 o'clock, right? So at 10 o'clock, I should be able to look at this AM clock. At 10 o'clock, where should the patient have been positioned? On their back. So I'm going to look at this patient. If they're not on their back, I know that we're not following our turning clock. So I'm going to put the patient on their back because that's what my turning clock says their position needs to be. But when we're doing this, we're going to go from the back to the right and then back to their back. 2 hours later, left side, back to the back. 2 hours later, right side. 2 hours later, back to their back. So left, right, left back, right back, left back, right back. Notice there's no stomach on here. Do not put an immobile patient on their stomach unless the care plan specifically tells you to, because they may not have the strength or the nerve involvement to lift themselves off of that chest cavity to inflate their lungs. This is why we don't put babies on their stomach. They may not be, remember, there's a lot of weight back here. Your spine, your muscles, your scapula, there's big bones back here. Bones are heavy. They press down. And your baby may not be able to lift off of that chest cavity to inflate their lungs. We don't put babies on their stomach. We don't put immobile people on their stomach unless the care plan specifically tells you to. Now, I've been teaching this for a very long time, way before COVID, right? Don't put people on their stomach. And it's funny because during COVID, we actually found out there was a nurse that was caring for patients in the ICU, patients on vents. She put a patient on their stomach. We have special beds that can do that because the patient had a lot of secretions and she wanted the secretions to be able to be helped out by gravity. She put the patient on their stomach on the special bed, and it actually helped with COVID. So those care plans would have said to put the patient on the stomach. Although I've been telling you, don't put people on their stomach. Remember, we follow the care plan, right? Good? Does that make sense? All right. So when we're doing this movement of the patient, right, back, left, back, right, back, left, the patient always needs to be in the middle of the bed. So when we're doing this, we're going to scoot the patient toward us and then roll them away from us using pillows to keep them there. Go ahead. Yeah, never leave your patient looking like this. Your evaluators are looking for this. I'm going to tell you a secret that I was told by an evaluator. The evaluators have seen this slide. The evaluators have seen this slide. That means the evaluators have seen this lesson. They are looking for this. I want you to think about that, okay? If the evaluators have seen everything that you are seeing, that means that they are being trained on the same content that you are using to learn. So if it's up on the screen, that means the evaluator has been trained to look at it. Got it? Okay. All right. So we're going to scoot the patient toward us before we roll them away. And this is so important. When you get that patient on their side, stop and look. If they're not in the middle of the bed, start over. Don't wait till you get all the pillows in place and then go, that doesn't look right. Stop and look. Go ahead. Go ahead. All right, so let's talk a little bit about how to move a patient. So our care plan does not say our patient is immobile. For the test, we're just going to ask, hey, scoot toward me. They will. It's all fine. But in a clinical setting, we don't always have that ability. So in a clinical setting, we've got a couple different ways that we can move a patient toward us in bed. One of them, my favorite, is the draw sheet. I love draw sheets. Draw sheets are great. They're slings. That's all they are. It's a long sheet. It's one of these sheets. But instead of folding it in half this way, we fold it in half this way, right? Long ways. And then we put this underneath the patient. This edge goes between their shoulders, right here. This edge where the two halves kind of join, overlap, this goes under their thighs. But this goes underneath the patient this way on the bed. And I can actually use this as a sling to lift the patient up and scoot them toward me. Love draw sheets. You won't have them in all places though. And there's some situations where we don't want to use draw sheets. That's up to the nurse, follow the care plan. But if we don't have a draw sheet, you can move the patient in segments. So head and shoulders, torso, hips, legs. Good. There's also something else that's super cool. It's called a slide sheet. These things are crazy expensive. So they're probably locked up in a supervisor's closet somewhere, and you got to sign them out and promise to bring them back and all that kind of stuff because they're super expensive. But if you put a slide sheet under somebody, you can almost move them with one hand. I mean, it is super slippery. It's not wet. It's just what they call frictionless, and it just slides the patient. Depending on your facility, they may or may not have one of those. Yeah, they usually don't. They're expensive. Expensive. Go ahead. All right. So how do we turn a patient that can't move on their own, can't roll on their own? How do we turn them without hurting ourselves or them? So this is all about prep work. Now, it depends on which way you're turning the patient. Do you guys remember what our care plan told us? Okay, we have to turn the patient onto their left, which if you're looking at this patient is this side of the patient. So my patient needs to end on this side. Do I turn a patient toward me?
No.
So where do I have to be? I need to be on the other side of the bed. So keep that in mind when we're talking about this, because the way I'm going to explain this, it depends on which side of the patient you're on, okay? If I had turned this patient on the right side, I would be over here. Everybody understand that? Okay. So when you're going to turn the patient, the furthest arm away from you goes up. So if I were turning the patient onto their right side and I was on this side of the bed, it would be that arm I would put up. But if I was turning the patient on the left side, which is what our care plan says, I'm going to be over here on this side. And that means the furthest arm, that arm, has to go up. Okay, so it's the furthest arm. Got it? Furthest arm up. Closest arm crosses the chest. So it looks like this. If I were turning them on their right side, it would look like this. Good? Closest knee is going to be bent. Closest knee, we're going to bend the knee, and we're going to put the foot flat on the bed. She doesn't bend quite that well, but we're going to put the foot flat on the bed. Okay, so this knee is tented up. The furthest knee, that one over there, is going to be angled out. So I'm going to bend the knee, leave it laying on the bed, but it's going to be angled out. So at the end of this prep work, arm up, arm over, knee bent, knee angled. My patient's already half on their side. I haven't had a manhandle them. I haven't even tried to turn them yet, but they'll already be half on their side because this positions their top half in this direction. This leg angled and this one tented puts their bottom extremities in that position. So all that's really left is like right here. Good? Does that make sense? You can turn somebody 3 times your body weight using this process with no stress on you or them. Go ahead, Jake. Thanks. All right, so you'll have to reposition camera. Sorry, I moved. All right, so we're going to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. That's our care plan. We're going to follow these principles. So we're going to follow that care plan. That's step 1. We're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I'm here to turn you on your side. Is that okay? Close curtain, wash hands, get my supplies. I'm going to decide if I need gloves. Now, this guy is not immobile. He just can't roll. Remember our care plan. He's wearing a patient gown. As long as he is holding on to all of his own body fluids like a champ, and he has no open skin that I am going to touch, no incisions, no rashes, no wounds, I don't need gloves for this. So for the test, you guys are all the patient for this. Now, when you're the patient, they're going to keep you fully clothed. Please do not take your clothes off during the test. Stay fully clothed. But they will give you a patient gown to put on over your clothing. Okay, this is kind of a simulation. Pretend, yeah. But you guys are holding on to all of your own body fluids like a champ, I'm sure. Sometimes, yeah. Don't sneeze, but you know. All right. So for the test, you really shouldn't need a set of gloves. Does that mean that every time you turn a patient, you won't use gloves? No, it means you have to look at each patient individually as to whether gloves are required. But for the test, you probably don't need them. Good? Make sense? All right, since we have supplies, we need a place to put them. We'll get a barrier and put our supplies on the table. We're going to use a privacy blanket for this skill. We don't snap it or shake it. We just lay it down, pull the sheet down underneath. And remember, you don't hold anything up next to your uniform for this skill. Patient has to be in the middle of the bed. And now we're going to get into our test-specific steps. So these are the checkpoints we're getting checked off with this position. Okay. We're going to assist the resident to turn onto their side and keep them positioned at a safe distance from the edge at all times. Go ahead. We want to make sure that they're positioned on their side with the upper knee bent in front of the lower leg. So when we turn this, remember we tented this leg, this knee? We bent the knee, put the foot flat on the bed. When we turn the patient, this is how the knee should fall. Good? Good. All right. It tells us to use a positioning device behind the back. So we're going to use a pillow and a roll behind the back. Rolled and tucked is the best way. So I'm going to put the one edge of the pillow underneath the patient's back, and I really want to get it under them. And then I'm going to roll the other edge up and tuck that under too. Now, if that pillow tries to flop out at you on the state exam, and it probably will, if you don't tuck it deep enough, it'll flop out. If that pillow tries to flop out, here's a little cheat. You've got the patient on their side, you put the pillow in place, it tries to flop out, tuck it back in, and then just grab the patient's shoulder and kind of roll them back onto that pillow a little bit. And that'll hold that pillow in place. And use their body weight. Go ahead. Now we're going to come around to the legs, lift that top leg and place a pillow between the legs, specifically between the knees and the ankles. Those areas should not rub together. So we'll lift that leg, put a pillow there to pad. And then we're going to put a pillow under the upper arm. This is a graded checkpoint. We have to put a pillow under that upper arm. Make sure the pillow doesn't cover the face. Makes sense? It should be, you know, under the elbow and under the hand. So it should run the length of the forearm. And that holds that arm up in a neutral position, helps prevent tension headaches and muscle spasms along the upper back. Remember, this patient's going to be in this position for 2 hours. We want them to be comfortable. And then we're going to go ahead, adjust the pillow under the head. That pillow should be under the head and neck, not that shoulder. So you probably have to lift their head up a little bit and pull that pillow out so it's not underneath the shoulder. Make sure the head and neck are well supported. And then we're going to put that call light directly in that bottom hand. You don't want to put it in the top hand because this cord, if it crosses the patient's neck, is a choking hazard. So we want to put that call light in the bottom hand. Now, the video I'm about to show you, I put the call light in the top hand. This is a change in the last 8 years. This has changed. So the new videos will have this, but the video I'm going to show you, just remember, call light goes in the bottom hand for this. Okay. And then we're going to do our closing. Thank you very much, Ms. Jones. Is there anything else I can do for you while I'm here? Are you comfortable? Bed is in low position. The environment is clean. I took away the privacy blanket, pull the sheet back up. Everything looks good. I'm going to open the curtain. Her call light's in the bottom hand. Go wash my hands and then tell the evaluator my skill is done. I probably would go back and look at the care plan one more time, just making sure I put the patient on the correct side. Go ahead. Remember that this care plan is just for this patient, not this one, not this one, just this one.
On their right side instead of their left side. Are you able to say correction? I would have put them on the other side.
Depends on your evaluator and how badly they want that margarita.
Really bad.
Some evaluators are sticklers and they will make you do the entire skill again. Some evaluators are like, nope, my margarita is way more important to me. I know they got it. I saw them do all the steps. They just messed up. So I can't give you a definitive answer on that. It really depends on how much of a stickler your evaluator is. Brand new evaluators are by the book. All right. So let me go ahead and show you this video, and then we'll get into our next skill.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head,
and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the two legs by lifting the top leg and laying the pillow lengthwise between the two legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done.
All right. Any questions on that one? Any questions?
So basically, when you roll somebody over, so you should put the borders on your head, like closest onto their shoulders. And-
So not under their head, just up.
okay, over.
Up and over. Knee bent, knee angled. Okay. That's a fun one to practice.
Yes.
That's a fun one. All right. Any questions? Any questions? We're going to go ahead and take our break. When we get back, we're going to get into foot care, which is just like hand and nail care, a little lower.
Okay.
Okay. So go ahead and take your break. Thank you. Oh, you got it. Okay. Go ahead.
You are.
Okay. All right. I know it's so sad when break time's over, isn't it? Okay, so now we're going to move on to foot care. Foot care is hand and nail care, just a little bit lower. We're not doing anything with the toenails. So remember with hand and nail care, we cleaned under the edge of the nails and filed the rough edges before we put lotion on. We're not going to do that with the feet. We're simply going to soak the foot, wash the foot, rinse the foot, dry the foot, and lotion the foot. So it's not a hard skill as long as you can get on and off the floor, because that's where you're going to need to be to do this. So if you look at page 118, this gives us a brief overview of the skill. You can see all of the principles going down the side. They're all spelled out for us here. Down here is skill-specific information. You have 13 minutes to do this skill. It'll be done on a live testing student. So yes, one of you may have somebody washing your foot. This is a great excuse to go get a pedi before testing. But yes, somebody, and I get it. Not everybody is okay with people touching their feet. Not everybody's okay with touching other people's feet. I understand that. But this is an essential skill for us to be able to do because our patients are going to require it. We've talked a lot about the changes of aging, and one of those changes is a decrease in flexibility. Right now, you guys can probably look at the bottom of your feet. If something felt wrong, if you felt like you had a cut there, you could pull your foot up and take a look at the bottom of it because you're flexible. But as we age, that flexibility actually decreases. Joints get stiffer, muscles get less elastic. You just don't move the way you used to. So if you can't look at the bottom of your feet, somebody has to. And that's what foot care is all about. There's actually another part of that we're going to get into in just a few minutes. But remember that you might be a student for this. This student will start out in a chair at the beginning of this skill. Charting is not required. Go ahead, Jake. Page 119, we'll have our care plan at the top of the page and step-by-step instructions, and all of our supplies are down here. This one has a lot of supplies. Not as many as hand and nail care, but there's still a lot of supplies here. We did get our flashcards in, so anybody who would like to get the flashcards to learn the supplies, we do have them available. See Jake after class. And like I said, you can always make your own as well. So step-by-step instructions, care plan at the top, supplies at the bottom. Our care plan tells us to provide foot care to 1 foot using soap and water. How many feet are we doing?
1.
What if the patient has 2?
1.
We do what the care plan says, and the care plan probably isn't even going to tell you which foot you get to pick. They don't care. As long as they see you wash 1 foot, rinse 1 foot, dry 1 foot, lotion 1 foot, they know you got it. They're good. It tells us the resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. So I'm going to time out here for a second and explain why that's on the care plan. Any care plan you see in the future will not have this on it. This is specifically for the test, and that's because this is done on another testing student. Now, normally out there in a clinical setting, when you're doing this on live patients, you're going to put clean socks on them. They've got clean feet. They need clean socks, right? That's just kind of a no-brainer. But for the test, you don't have clean socks. When you go to the test, they don't tell you to bring an extra pair of socks with you. You have no clean socks. So this causes confusion for students on the test. What do I do after I wash the foot? Do I just leave it bare? What do I do? So the care plan actually addresses this, and that's so that the evaluators can say, if you voiced a question like that, look at the care plan. Does that make sense? Okay. Remember, those evaluators cannot answer questions for you. All they can do is refer you back to the care plan. Now, we know we follow the care plan, so this is a no-brainer for us. But for a lot of people taking the test, they have no idea what a care plan is. No idea. How many of you guys have your yellow books with you? Anybody have a yellow book? Okay. I want to show you something really quickly because I don't think I did this on day one. Open up your yellow books real quick to the index, the very back of the book, and look up care plan. Tell me what page that's on in the index. What is it? Okay. What page is does care plan show up on the index though? I mean, the 271. Okay. So on page 271, if you look at care plan, you'll see that it refers you to page 7 and 8 in your book. So go to page 7 and 8. What do we know about the care plan?
Oh, exactly.
Follow it, right? So the care plan dictates everything we do. If it's on the care plan, we don't do it. I mean, that is our entire job is the care plan, right? This book mentions the care plan once. Once on page 7 and 8. That's it. This entire 250-page book talks about the care plan once. None of those skills that you see on chapters 6 and 7 that you're about to read, you're going to read chapters 5 and 6 tonight. None of those skills tell you about the care plan. So if this textbook, which is the second most used textbook in CNA training throughout the country, if this textbook is only talking about the care plan once, and the instructor never talks about the care plan, do you think that every student going to test understands what a care plan is? No. You guys take it for granted because that's the way I've taught you. But a lot of the people that you're going to be testing with do not have the same level of knowledge that you do. I teach it this way so that it becomes a, well, duh issue for you. But I do need you to understand this is not how everybody is taught. Okay? So the sock and shoe should be replaced at the end of the skill. This care plan is telling you specifically for the test, this is what we want you to do. That way you're not leaving somebody sitting there with one sock and shoe on and one bare foot, which is just like weird. Okay. Go ahead. All right, so let's get into our skills specific. We already know all of the principles we need to know for this. There's nothing to learn here except for what we have to do for this particular skill, right? We know to follow the care plan. We know how to do our opening. We know to evaluate if we need gloves. We know how to use a barrier, except this time the barrier will go on the floor. We know how to use linen rules, so nothing pressed up against you. Have clean hands to get your clean linens. Anything you don't use, you discard. We know how to clean the basin. We know how to use washing rules. We get water, they check it. We check it, they check it. Don't put soap in your water because you need clean water for rinsing. We know all this. Nothing new here. And we know how to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you? Are you comfortable? Bed is in the low position. Environment is clean. Here's your call light. Let me open your curtain, go wash my hands, and end my skill. We know how to do all this. This is nothing new. Let's learn this stuff, though. And believe it or not, there's nothing really new here either because we've seen it with hand and nail care. This is a super easy skill. Go ahead. There's a lot of correlations here. Remember with hand and nail care, we had to support that wrist and arm when we moved it? Well, we're going to do the same thing with the foot. With hand and nail care, we soaked the hand in water. Well, we're going to do the same thing with the foot. With hand and nail care, we washed and rinsed and dried. Well, we're going to do the same thing with the foot, right? There's a lot of correlation here. Where this changes is that we're not going to do anything with the nails. We're not going to clean them. We're not going to file them. We're not going to grind them. We're not going to trim them. We're not doing anything with toenails, but we are looking at them. Because if your patient has a toenail issue, we need to let the nurse know because there's a podiatrist that comes to the facility every month. Now, that podiatrist does not go room to room looking for victims. They don't go in and say, you need me? Do you need me? They don't do that. The CNA does foot care, sees there's a problem, notifies the nurse. The nurse puts the patient on the list And when the podiatrist comes in, he looks at the list and sees the patients on the list. If you don't do foot care, or you do foot care and don't notice, don't let the nurse know about any issues you notice, nobody's going to address them. Good. So nothing with nails. But we are going to inspect all surfaces of the foot. We're looking at the heel of the foot, the ball of the foot, the entire underside of the foot, the top of the foot, between the toes, the toenails. We're looking at all of it, and we're looking for anything that needs to be reported, anything weird. And then we'll report that to the nurse. Because we don't know if there's an issue. That's the whole reason we're doing this, by the way, is because we don't know if there's an issue. We need to wear gloves. Because remember I said that we are going to wear gloves if there's an open wound or a possibility of an open wound. Well, with this one, there's a possibility because nobody has looked at the bottom. Patient can't look at the bottom of the foot. We don't know. So we're going to use gloves because it's a maybe. Make sense? Make sense? Okay, we're going to put the sock back on, wrinkle-free. Remember, wrinkles can contribute to pressure areas, pressure source. And then we'll put that shoe back on. The one thing that's a little bit different is when we put lotion on the hand, we put it everywhere. We'll just put lotion on the hand. But when you're putting lotion on the foot, you don't want to put lotion between the toes. And that's because lotion is going to hold moisture in the area. Between the toes is already warm and dark. We don't want to hold moisture there because it can contribute to fungal infections. Ugh. Go ahead. All right, so we're going to follow the care plan. In this care plan, let's read it one more time. Provide foot care to 1 foot using soap and water. Resident is sitting in a chair. Their sock and shoe should be replaced at the end of the skill. So once we know what to do, every skill starts with the opening. Every opening starts with, go ahead, Jake. That's right. So we're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I'm here to do foot care. Is that okay? And he's always going to say yes, because the tests, our patient, are pleasant and cooperative. And I'm going to close the curtain, wash my hands, and then start gathering my supplies. One of the supplies that I may need are, go ahead, gloves. And we're going to use gloves because this is a maybe. We don't know if there's any wounds or any issues. So we will wear gloves for this. Another supply that I'm going to need is a barrier. This is a place to put all of my supplies. In this case, the barrier will go on the floor because that's where we're working. We'll get the rest of the supplies that we need, not allowing them to touch our uniform, being careful not to snap or shake them, and don't put anything dirty on the floor. Remember, nothing goes on the floor. Everything stays on the barrier. Super important. And then we're just going to wash. We'll go to the sink. We'll use a paper towel, turn the faucet on. We'll check it. It should feel warm. Not hot, not cold, just warm. Fill the basin, half full, third, whatever you can carry, half full, third of the way full. Bring it over to the patient and have them check the water. We're going to put the foot in the basin to soak, take it out and put it on a towel. Remember, we want it soft surface. Take the foot out, put it on a towel, and we're going to put washcloth on, going too fast, put soap on the washcloth to wash the foot. We'll put that soapy washcloth aside on our barrier, supporting the foot, put it back in the basin to rinse. Second washcloth will rinse the foot. After it's rinsed, we're going to take it out of the water and put it on the towel to dry. Once we've dried, then we can put lotion on all areas. But that whole process, while we're washing and rinsing, we need to be looking. It's the whole purpose of us being there. So you have to say out loud, I'm looking at the foot. Or I don't see any red areas or abnormalities. Or do you have any sore spots that I need to be aware of? You need to let that evaluator who's watching you know that you know why you're there. You should wear gloves for this skill. You should, because there's an unknown, because you don't know if there's a wound. That's the whole reason we're doing this, is to find a wound. Because it's an unknown, you should wear gloves for this. Yes.
And when do you put the gloves on after we wash the hands?
So we've washed our hands. We went and got our barrier and put it on the floor. We went and got our washcloths and our towel and our basin, our soap and our lotion and put those on the barrier. Then we're going to go to the sink and get our water. We're going to check it. They're going to check it. We put our basin down, put the foot in the basin. Now we can put our gloves on, because the first thing your gloves should touch is the patient. Good? Questions? Okay. Once we've washed, rinsed, and dried the foot, and we've looked at the foot, and we said that we've looked at the foot somewhere in there, then we can put some lotion on. Remember, we warm it up first, put the lotion on, and then we wipe off the excess with the towel. We're going to put the sock and the shoe back on, making sure there's no wrinkles in the socks, and then we're just going to clean up. Go ahead. When we clean up, we're going to dump the basin, the contents of the basin in the sink. It's just washing water. It can go in the sink. If you want to put it in the toilet, I don't care. But dump the basin, rinse it out, dump the rinse water wherever you dump the basin water. Set it down. We're going to pick it up with a paper towel, dry the inside, dry the outside, and then go get your supplies and put them in the basin and open the drawer with that last paper towel. Once you have everything stored, you'll get your dirty linens and put them in your dirty linen hamper, whatever that is for the test. That will be right next to your work area. After you've got the entire area cleaned up, you've taken care of your basin soap and lotion, you've got your dirty items in the hamper, you threw your barrier away, everything is nice and clean, take your gloves off. Don't do your closing with your gloves on. Do you want to touch that curtain with these gloves?
No.
Do you want to touch the call light with these gloves? No. Okay. So please make sure that you have your gloves off for the closing. Go ahead. So skill-specific steps. Remember, these are our checklists, right? This is what we want to get checked off. It wants us to soak that foot in a basin of water. Well, we did that. We got that checked off. It wants us to, go ahead, provide support as we're moving that foot from place to place. Go ahead. We're going to wash, rinse, and dry the entire foot. We don't put lotion between the toes, but we put lotion everywhere else. Main job is to look for abnormalities. So you want to look at the bottom of that foot. See how I've held it up? I want to see the bottom of that foot. Go ahead. Don't put that bare foot directly on the floor. That just makes sense. Okay. Put the shoe and sock back on. No wrinkles, leaving socks smooth. They're grading us on that. And then make sure you fasten the shoe appropriately. Now I'm going to tell you a little secret for the test. There's a couple of skills that require that you put shoes on the patient. So when they are matching you up, okay, with another student, you guys remember that part of the test? You come in, you get checked in, they verify that you are you, they send you to a waiting room, and then they disappear for a while. They're matching you up with another testing student. That's going to be your patient for the test. So let's say that you have foot care. Okay. I know based on your Prometric ID, I know what skills you have. It's coded right in. So I know that you are going to have to do foot care. Remember, for the test, you have to wear closed-toed shoes. Everybody wears closed-toed shoes. But as other people are coming in, I'm just kind of taking a look around. I take a look at what you're wearing. It's part of my assessment. She's going to be your patient for this skill. And the reason that she's going to be your patient is that she has slip-on shoes and socks. So that makes it easier. You don't have to worry about tying shoes. So when they match you up on the test, they do kind of try to make this as easy as they can. Good? That makes sense? Doesn't always work out that way. Sometimes we have to put you with somebody with tied shoes. But for the most part, if we can, we're going to try to make this easy. Because where do the evaluators want to be?
Home.
Home in their pool drinking their margaritas. They don't want to wait. They do not want to watch you tie a shoe. They figure by the time you've gotten to this point in your life, you've got shoe tying down. I don't need to watch that. Okay. Good? Good. All right. Then we'll finish up with our closing. Okay. Remember that this skill is for this patient. It is not for this one. It is not for this one. These guys may not have foot care at all. These guys may shower themselves. I don't know what their care plans say, and truthfully, I don't care what their care plans say. That has nothing to do with me. This care plan is for this patient, and that's what we're going to follow. Good? Good. All right, so let me show you. I'm not getting on the floor. That is not happening. Let me show you this video.
Hello,
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. You want to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands and Apply lotion to all surfaces except between the toes. So I'm going to lift your foot, and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There we go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Any questions? Yeah. Any questions? Foot care, just like hand and nail care, a little lower, no nails. Big part of this, though, is to look at the foot. Okay? Go ahead. All right, we're going to move on to mouth care now. This is on page 92. This is not a hard skill, guys. You all know how to brush teeth, I'm sure. What we have to learn is how to brush somebody else's teeth, which isn't much of a stretch. All right, so if you look at all the principles down the side here, they're all spelled out for us here. There's nothing there we don't know already. Everything there is something we've already covered. So the only thing that's left to learn for this skill is this stuff. That's it. And considering I'm pretty sure you guys know how to brush teeth, this is going to be pretty easy. This isn't going to take a lot of time. Okay. After this skill is over, we're going to go into test registration. So we're going to pass out the registration forms, and I'm going to go through the whole registration process with you so you know what to expect, the timeline, the steps involved, all of that before we leave today. Starting next week. So I have packed. Remember on day one, I told you I'm going to talk nonstop for 4 hours, yes. Right? And I meant it. So the first 2 weeks, you have no time in class to do anything yourself. It's all me talking. Starting next week, we will get into practice time built into the class. So at the end of each class, you'll have a certain amount of time that you'll be able to practice the skills that we've learned. Some of the skills you can practice at your table, like pulse, respirations, blood pressure, of course, which is not a tested skill. Remember that. Blood pressure is not tested. Hand care, foot care, feeding a resident when we get to that one. So there's a lot you can do over there. You'll also have the mannequin in the bed to practice mannequin skills. So you'll have some time built in. Now, on Monday, which is class 5, you won't have a lot of time, maybe a half hour. On Wednesday, you're going to have about 45 minutes to an hour. The following Monday, you'll have about an hour and a half. And on the last day, you'll have about 2 hours. So there is time from this point forward built in, but not today. Today, we're going to talk about test registration.
Are we going to take a practice test or no?
The practice test is actually in your book.
Okay.
And we're going to talk about that on the last day, but it's on page 191 of your book. And it is a full 60-question practice test, very similar to the state exam. But you should also be watching our game show replays as well. So if you go onto our YouTube channel, 4YourCNA, under playlist, find the game show. And I do 15 test questions every game show. Our next game show is next Tuesday. So a week from yesterday. So you can tune into that live. If you play live, you can actually win prizes. Like we give away the card game. That's one of our prizes. We give away a CNA t-shirt, and there's like 4 or 5 you can choose from. We give away badge holders that the only way you can get them is to win them. So they're not sold. You have to win it. So if you play live, you can get prizes. So Tuesday at 11. But yes, we have. I also have a practice test on the website as well. In the course, there's over was it 1,500 questions in the course, and you guys all have access to that online course. You were all enrolled in it. So yeah, there's tons and tons and tons of practice test opportunities. Good. Questions?
I did the online course last night.
You did? Very good. Very good. Did you find it helpful?
Yes.
Good. It helps reinforce the principles that I'm teaching in the class. All right. So go ahead and advance me, Jake, please. So page 93 has our care plan at the top, has our supplies at the bottom. We've got some step-by-step instructions here. When you're looking at these pages, these step-by-step instruction pages, there's always a gray box. After we do the skill, you should be able to look at that gray box and answer these questions. If you can't answer these questions, then something went wrong somewhere and you don't have the information you need for that skill. You need to bring it to my attention. You need to say, hey, I was looking at these questions and you didn't tell me anything about number 4. Can you go over that with me? Because remember, I'm doing this from my head without notes. I talk about what comes on the screen, but this is all me. I'm just giving you information. Is there a possibility I might have missed something? Yeah, maybe. I've been doing this long enough that I'm probably not missing much. But if you go through this and I didn't answer something, you need to bring it to my attention. And I'll make sure you have the answer. Okay?
You can also find the answer in the book too.
The answers are in the book, yes.
Highlight where to find them.
Good. Very good. Very good. All right, go ahead, Jake. So this is our care plan. A resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care. Do we care why they can't do their own mouth care? No, it doesn't matter to us. Just they can't do it, so somebody has to. It tells us our patient with natural teeth. So somebody in here is going to say, but wait, what if they have dentures? We're going to cover that on Monday. Dentures is a little bit of a different process. So this one, we're going to start in kindergarten before we go to 8th grade. So we're going to start with just mouth care. And then next week, we will do denture care, which is a step up. Good? Good? All right. So we know all of those principles. We're going to focus on these steps that we need to learn. Go ahead. So again, we're going to follow our care plan. We're going to do our opening. We definitely are going to use gloves for this because there's body fluids involved. And we need a barrier to have a clean place to put our clean supplies. When we go get the supplies, we're only going to touch them with clean hands, and we're not going to hold them against our uniform. We're not going to shake or snap them. And after we use them, they'll go into dirty linen, never on the floor. When we clean the basin, we're going to clean it the same way we clean all other basins. And we're going to do our closing the same way we always do. So let's look at the skill-specific steps. This patient is lying in a bed, and this is how your patient will start this skill. They will be laying down in bed, just like this lady here. Is this a safe position? What do we need to do? Put the head of the bed up, absolutely. And that's what this checkpoint is telling us. Put the head of the bed up. But I want to time out here for a second because I'm going to show you just how easy the test is. You guys get all tangled up in these principles, and I want to read this checkpoint to you, and I've got a purpose behind it, but stay with me, okay? This checkpoint says, assist resident to a sitting position in bed by raising the head of the bed and using pillows as needed to position the resident upright at 60 to 90 degrees before offering fluid or brushing teeth, okay? So we got to put the head of the bed up. That's what it's saying. Got to put the head of the bed up before we start brushing our teeth. Pretty straightforward. What it does not say is that we have to do that before we wash our hands or after we wash our hands, or it doesn't, there's no graded checkpoint that says when this has to happen. The only thing that it says is before offering fluid or brushing teeth. That is the only before that's in this checkpoint. You guys will get all tangled up in this. The test won't. So a lot of students complicate this skill needlessly. When we put the head of the bed up, we're going to use the things that we've already learned to figure out when we should do this to have the best effect for the patient. Okay? So I'm going to help you reason this out. Is that bed controller clean?
No.
Who touches it? Okay, keep that in mind. Jake, go ahead. Keep that in mind. Okay, so we know that this is not a safe position, but here's the problem. Yeah, if you miss this step, if you don't put the head of the bed up, you will fail automatically. We killed our patient. We should fail. But when you are standing at the sink brushing your teeth, do you stand at the sink in this position?
No.
You stand at the sink in this position. You lean forward. Why do you lean forward?
So we can sip it all the toothpaste out.
Right. So you're going to be a foamy mess. We don't want that mess to drip down on us. We want it to drip down into the sink. When we put the head of the bed up, it's not going to lean the patient forward like we do when we're brushing our teeth. They're going to be semi-reclined still. Do you guys see that? All right, go ahead, Jake. All right. So our cardinal rule, and I've been saying this every class, you should know this. You cannot touch the patient until your hands are clean. So keep that in mind, right? This is our cardinal rule. Can't touch patient until our hands are clean. All right. It's a checkpoint. So if we are going to put the head of the bed up, we want to get that patient sitting up as far as we can, not reclined. We want them as far up as we can. So in order to do that, we are going to have to slide this pillow down behind their shoulders, not behind the head. When we put the head of the bed up, the pillow is still back here behind their head. We need it behind their shoulders. They have to lean forward. We're going to slide that pillow down. Can we touch that patient until our hands are clean? No. So we have to wait until after we've washed our hands to slide the pillow. We know that bed controller is dirty. Do we want to touch it after we've washed our hands? So we got a problem here. Houston, there's a problem. If I wash my hands and then touch that bed controller, I've contaminated myself. But if I put the head of the bed up and adjust the pillow before I wash my hands, I contaminated the patient. So what do? The way that we approach this is that we wash our hands, and then we're going to put the head of the bed up using a paper towel as a barrier. Once the head of the bed is up, we can slide that pillow down, and now we've got all of our checkpoints. Good? Does that make sense? Do you guys understand the why behind that? Okay. So now that we got the patient sitting up, pillows behind the upper back, we're going to get ready to start brushing teeth, but this patient's still going to be a drippy, wet mess, foamy. They're not leaning forward. They're sitting up, but they're not leaning forward, so we want to protect their clothing. What can we use there?
Towel.
A towel, a washcloth, a barrier, a paper towel. I don't care what you put on them. Just cover their clothes. Tess doesn't care what you put on there. Just cover the clothes. That's all they care about. So put something on there. Okay. We're going to wet our toothbrush before we put toothpaste on it. This is the same principle as when you wash your hands. You've got to wet your hands before you put soap on to make sure the soap spreads well. We got to wet the toothbrush before we put toothpaste on so that it spreads well. Same principle there. Don't use a lot of toothpaste. We, for some reason, think that a big stripe of toothpaste is best. It's not. Pea-sized amount is all we need. That's it. Anything else is going to be wasted. But it's even worse when you're brushing somebody else's teeth. If you use a lot of toothpaste, that toothpaste has nowhere to go. It's in their mouth. It's in the way. It can actually be a choking hazard. But when you're brushing somebody's teeth and you got a ton of toothpaste in there, they're going to have to rinse for 30 minutes. I mean, you're going to be standing there forever helping them rinse. This is a time management issue. A small bit of toothpaste is all you need. Don't overdo it here. Okay? You're going to brush. Now, again, students get all wrapped up in this. Well, how long do you have to brush for? Doesn't say. Just says brush sides and biting surfaces of teeth and the gum line with a gentle motion. It doesn't say the top has to be done first and then the bottom. It doesn't say the front has to be done first and then the back. They don't care. Brush the teeth for as long as it takes. Just brush them. Now, I like to divide the mouth up into 4 quadrants because that's just easier. I do the back on the top and the back on the bottom. I do the back on the top and the back on the bottom, and then I come back and do the front. I can do it all pretty quickly. Okay. And then we're going to give them something to rinse with, a cup of water. That care plan did not say they couldn't hold a cup. Remember, don't read anything into this. For the video, I do bring the cup up to his mouth to show you how to do that. But you can hand them the cup for the test. It doesn't say they can't use the cup. All it says is offer resident a cup of water to rinse mouth. So they can do that. Provide an emesis basin or disposable cup to let them spit into. Give them somewhere to spit. That makes sense. Now, if we use a emesis basin, we're going to have to clean it and put it back. If we use a disposable cup, we're going to have to dump it and throw it away. I had to pick one to show you for the video. Can't show you both. That would be confusing. I had to pick one. So in the video, I use an emesis basin instead of a disposable cup because I want to show you how to clean the basin and put it back. Make sense? Remember, when I make these videos, I have to pick one thing to show you, one way. Doesn't mean that that's the only way it can be done. Good? Questions? Go ahead. All right. This is the one step that gets missed on mouth care. I don't know why, but almost everybody misses this step. And I think it's because you're concentrated on your steps, not the patient. Remember I said at the end of the skill, you should always take a step back and look at the patient? This is why. Because when you're all done with brushing the teeth and they rinse, you're now in cleanup mode. Your brain will automatically go to cleanup mode. Okay, what do I have to do? I got to go clean the basin. I've got to take care of my cup and my toothbrush and all. You're in cleanup mode, right? You don't stop to look that that patient is a drippy mess. And while you're busy cleaning everything up, the patient's just sitting there dripping, 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 drip. How comfortable is that patient? Yeah, don't forget to wipe their mouth off before you clean up. Clean the patient before you clean the supplies. Remember, it's always about the patient. And if you can remember that, I've got to clean the patient before the supplies, you won't forget this step. Okay? And then we'll do our closing.
I have a question.
Yes?
So will we have to clean clean the patient's mouth, or will they be able to do it themselves?
Let's look at the care plan at the top of the page. What does the care plan say?
It just says that a resident with natural teeth is laying in bed and needs mouth care. The resident is not able to provide their own mouth care.
So we're brushing.
Okay.
Okay. So could they wipe their own mouth? Yes, but it's a graded checkpoint, okay, that it's done. So whether you ask the patient to do it or you do it yourself, they don't care about that. What they care is that it's done. And you're not relying on your patient to think about doing it. You have to address it. So for me, I just pat their mouth dry. I wipe their mouth. But in a clinical setting, if I've got somebody who can use their hands, I may say, feel free to use that mouth to dry off, or that towel to dry your mouth. Make sense? Okay, so you can offer them the towel to dry themselves, but for the test, we really should take that extra step. You have to at least say it. If you're not doing it, you have to at least say it because you need that checkpoint. Good? All right, one more, Jake. This is probably the most common question I get on this skill. Do I have to brush everybody's teeth? No. You're only going to brush the teeth of the people that can't do it themselves. How do we know who we're helping with this? The care plan. Absolutely. We're not brushing everybody's teeth. And in fact, if somebody can brush their teeth, I do not want to be in their mouth. They don't want me in their mouth. And you're going to find this out when you guys are practicing. And you should not just be practicing here. You should be practicing at home too. If you have somebody at home that you can practice the skill on, this is one that they will resist. They'll be like, nah, let's just simulate this. Please don't brush my teeth. This is weird. I don't like this. People do not like people in their mouth unless there's a reason for it. So you are not brushing teeth of people that can brush their own. You're just not going to. They won't let you. This is one of the first skills we become independent at. Ask any 4-year-old, do you want me to brush your teeth? No, I do it. I do it. I do it. Okay. When you become independent at a personal care skill, you do not want to go backwards. You do not want anybody else to do it. So we are only going to help people with the things they need our help with. Go ahead, Jake. So this care plan's for this lady, not for this guy, not for this, not sure. This care plan's for this lady, just this lady, nobody else. Every other care plan for mouth care is going to be different because it's going to be based on their needs, not hers. Good? Questions? All right, let me show you this video. Let me tell you, time out real quick. Let me tell you this, right? The patient that you see in all these videos, that's my oldest son. He does not like being a patient. I have to use mommy credit to get him to be a patient for that. He does not like this job. Okay. And he especially does not like this skill. He really, I mean, I got to bribe him for this. He does a good job because as much as he hates having this done, he doesn't make a big deal. You don't see it on his face. He doesn't draw attention to him. The focus is on the skill. Okay. So hats off to him. He does a great job for me. But understand that your patients are not going to be comfortable with you in their mouth. They're just not going to be. So when you're doing this, please do it with a little bit of compassion, a little bit of heart, a little bit of understanding. But don't skip mouth care because your patient is uncomfortable. And I'll give you a great example of this. When I was working at the hospital, I was working in a step-down unit. So when you're done with the ICU, before you can go to a regular floor, they put you in a step-down unit, which means we're watching them a little more closely, but not as closely as ICU. This guy had been in a motorcycle accident, no helmet, hit a tree, closed head injury, also fractured his neck. He was paralyzed from about here down. He had been in the ICU for weeks. I don't know how long, but weeks. And this is a very long time ago. I can't remember the particulars, but I remember this part of the story very, very well. I noticed that when I talked to him, he would turn his head away from me every time he answered. He was always turning his head away from whoever was talking to him. Now I'm thinking this poor kid is depressed. I mean, and who wouldn't be? His life is all, completely changed, irrevocably altered forever. This is bad. So I'm thinking I'll get a psych consult for him because, he's obviously depressed. And I asked him, I said, can I ask you a question? How are you doing emotionally with all this? He says, well, it sucks. I said, yeah, but are you starting to feel a little, a little depressed, or, is there something that you want to talk about? So I'm trying to kind of gauge his mental outlook, his mindset. He's like, no, it sucks, but it is what it is. So I'm thinking, okay, wait a minute. This is a little more well-adjusted than I thought he was. So I said, well, is something going on? Because you're never looking at me when I'm talking to you. He says, well, yeah, I've got dragon breath. Nobody has brushed my teeth since before the accident. He's like, and I know that I'm offensive. This poor kid, I mean, he had been through the ringer, right? And he's worried about offending me with his breath. I'm like, no, wait, stop. This isn't about offending me. Nobody has brushed your teeth. He says, no, 6 weeks at least. Nobody had brushed his teeth. So now I'm not getting a psych consult. I have to get a dental consult. And he had multiple broken teeth from the accident. He had to have multiple teeth pulled. That's unforgivable, guys. It's unforgivable that we could see to this guy's major medical things, but miss something so foundational as mouth care. So if you're taking care of somebody that cannot brush your own teeth and there's nothing on the care plan about mouth care, please bring it up to somebody. Hey, should we be brushing his teeth? I mean, that's horrible. Let's not do that to our patients. Sometimes we focus so much on the condition that we forget about the human. Humans matter. Make sense?
Yes.
Okay, go ahead.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip?
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done.
Okay. Well, that's right. We got one more skill to go through. So Jake's going to be passing some things out. Are we out of copy paper? Okay.
I have a question.
Yes. Sorry.
In the video, I saw that you had touched the table before you washed your, or after you washed your hands. So should we have everything in place? Like the table and everything before we wash our hands?
Doesn't matter.
Okay.
Doesn't matter. And yeah, you can. How do I put this? They're not great. Remember, it's entry level.
Okay.
Entry level.
I know you're always saying, you know, how the cooties are around and.
Right. So everything in the patient's environment is contaminated with the patient's own cooties. So they're friends. They get along fine. It's basically there's no different cooties on this table as there is on her sheet. So theoretically, that's fine. Now this does change when you get into an isolation situation, or you know, there are different. That's why I'm trying to be very careful in how I respond to this. Right. In general, once you've washed your hands, you're free to touch the items in the patient's environment. I just want you to be aware of pathogen transfer. This is why we have the rule that the first thing our gloves should touch is the patient. Because even if I pick up some cooties from touching this, or touching the pillow, or touching other things in the environment, and I've got some of the patient's cooties on my hands, when I put my gloves on, that covers those cooties. So now I've got a clean surface to get into her mouth. but I don't want to put my gloves on and then touch the table and touch the, the toothpaste and touch all this other stuff, because now I have cootie covered gloves in her mouth. Does that make sense? So that one rule, the first thing our gloves should touch is the patient. And that shouldn't be to prepare the patient. That should be to do the skill. Okay. By keeping that principle at the top of our mind, we'll always make sure our gloves are clean. Okay. Does that help? This topic can get, I'm trying to keep you guys very surface level, because that is where CNAs are supposed to be, up here. Infection control goes way deep, ocean deep. And I can get into all of that, but it's not going to serve you at all. So I'm just trying to keep this very surface level for you. Okay. The test is not that stringent. They want you to wear gloves if you're going to touch body fluids, but they honestly aren't grading you on what you touch with the gloves before or after,
Okay.
as long as you're touching glove, or as long as you're wearing gloves when your hands are in the mouth. That's how surface level the exam is. I don't like that. I want you to have a little bit better understanding, because you guys are the ones that are going to put the patients at risk. Okay. Good. All right. So moving on to respirations. This is our last skill for today. So before we get into this skill, I want to go to page 49 for a moment. If you look at page 49, there's a lesson there on military time. When you are documenting for the state exam, you're going to get a documentation form for all documenting skills. And if you keep your finger there, but go to page 168, it'll show you the documentation form for respiration, so you can see what it looks like. But there's going to be a place on that documentation form for the time. I'm trying to think. Actually, respirations, I don't think has time on it. I know intake and output does. I don't know if respirations has time on it. But anytime that a form asks you for time, you're going to have to document time. And in healthcare, we have to document in military time. If you're not familiar with military time, you need to become familiar with it. So this worksheet on page 49 will help you understand what military time is and how to make that conversion.
Quickest way to do it is if the number is over 12, it's afternoon.
Yeah, just add 12. Add 12. Military time makes, I'm a very logical, linear thinking person. Way too logical, actually. So to me, military time makes more sense. There's 24 hours in a day. There's 24 hours on the military clock. That makes sense, right? Military clocks, we just use all the hours. It's easy. I don't know who decided we're going to get to 12 and start over. I mean, that to me is like bonkers. Why did people not know how to count past 12? I mean, what happened there? It doesn't make any sense to me. So military time is very, very intuitive, but not for everybody. And I understand not everybody is logical, linear thinking like that. So you may have to learn this. For anything after 12, you just add 12 to the number. Just add 12 to the number. If you use regular time on the test, you have to indicate AM or PM. So if I put 11:47, I put 11:47, I would have to put AM behind it. Now, if I left out the dots, if I just put 11:47, 4 numbers all squished together, it's military time. It is 11:47 in the morning. So I didn't need the AM. Leave out the colon, you leave off the AM. Good? Make sense? Okay. All right. So let's learn how to measure respirations. This is not a hard skill. We are going to count somebody's breathing. There's not a lot to learn in this one. We know all the principles we need to know. So for this skill, our care plan at the top of page 55 tells us that the resident will be lying in bed for this skill, count the patient's respirations for 1 full minute, and record your readings. Jake, can you advance me? Thank you. So that's our care plan. We know all the principles, so let's just focus on the steps that we don't know. Go ahead. Go ahead. All right, so we'll follow that care plan. We're going to do our opening. Knock, knock, knock. Go ahead, Jake. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today, and I'm here to, hold up. We don't want to tell this patient we're counting their respirations. If you tell them I'm counting your breathing, that's going to alter their breathing. So I'm going to count your breathing. Ready, set, go. Yeah, so now you're like, what do I do? You like all of a sudden forget how to breathe. So you don't want to tell somebody you're counting their respirations. What we're going to say instead is I'm taking your vital signs. Respirations is part of vital signs. They don't need to know which one we're doing at the moment. And we're going to go a step further and make it look like we're taking their pulse. And this is why. This is something that most people don't really think about. Okay. If I'm going to measure her respirations, I wish I could get somebody in this. I don't have, okay. So let's say this is a live person. Let's pretend you guys are in the bed. Okay. If I were to come over here and do this, how comfortable do you think this person is?
Not very comfortable.
Yeah, I'm not talking. I'm standing over them, looking down on them, and I'm not touching them. This is awkward. And that's going to cause anxiety. What do you think anxiety does to respiration rates?
It's going to be higher.
Yeah, it makes them higher. So are we getting an accurate reading by making this patient anxious? So what we want to do here is make the patient think we're taking their pulse. This, I'm still measuring the respiration. I'm not holding her pulse. I am basically holding her hand. But she doesn't realize I'm focusing here. She's focusing here. Does that make sense? So the two big things with this skill that most people don't really think too much about is you can't just stare at somebody without touching them. And you can't stare at them without talking to them. It's weird. Especially because with women, you're staring at their chest. That's pretty high on the creep meter. Okay. So you want to set this up so that they think you're taking the pulse. That relaxes them. It allows you to do what you need to do. And it'll give us a little bit more accurate reading. Make sense? So knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today, and I'm here to get your vital signs. Is that okay? Close curtain, wash hands. Now I'm ready to get started. Go ahead. Gloves. Might need them. Might not. The only area of this patient that I'm touching is their wrist. No body fluids there. So if they have an open wound, an incision, some non-intact skin, do I need gloves? Yeah. If they don't, do I need gloves?
No.
No. So decide with the patient you're working with whether you need gloves or not. Once I figure out whether I need gloves, then no, go ahead. You're right. Then I'm going to start the skill. Make sure I don't tell them that I'm counting the respirations. This is the actual checkpoint. This is how they term it. Measure the rate of respirations without providing instructions to the resident about how to breathe. So I don't want to say, I just need you to breathe deep. I just need you to, relax and breathe normally. We don't talk about breathing. They should not know we're doing breathing. Breathing should not be part of our vocabulary for this skill. Good? Okay. Go ahead. Now, in and out is counted as one full cycle. So, okay, somebody look at that clock. Okay, look at that clock. Notice how long it takes me to breathe in and out. Ready? Ready? How long?
3 seconds.
Watch closely. How long? Probably closer to 5 or 6 seconds.
Yes.
Okay. Now, I want you to stare at this patient. Glance at the clock, stare at the patient. Did that take 6 seconds?
No.
So the breathing process, in and out counts as 1, took 5 or 6 seconds, but you looking at that clock did not. You can time and count at the same time. Because remember, in and out counts as 1. So we're using that clock for timing, and our care plan is telling us we have to count for 1 full minute. So we're going to have to count for 1 full minute. So we got to look at the clock, pick a starting point, say start out loud, and then we're going to look at the patient. And they're going to breathe. Somewhere in there, I'm going to glance at the clock to see where I'm at. But I'm not going to do that until like respiration 8 or 9. Because normal is between 12 and 20. This patient should breathe somewhere between 12 and 20 times during that minute. Should. Everybody got that? So I really don't need to look at that clock until I'm somewhere around 8 or 9. That means I'm staring at their chest for a long time without saying anything. This is going to be uncomfortable for your patient. So you probably want to prepare them for it. I'm going to be counting for 1 full minute. I'll need you to remain quiet, but I'll let you know as soon as I'm done. If this patient knows that I'm counting for 1 full minute, they won't get anxious because I just told them that's what I'm doing. There's nothing unusual about that. But if they're used to, somebody just doing vital signs really quickly and I'm standing there for 1 whole minute, they're going to start thinking something's wrong with them. And they're going to start asking, what's wrong? Am I okay? Is there something going on? And that will completely derail your count. Make sense? So in and out counts as 1. It doesn't matter when you're counting respirations, whether you start counting on the inhale, whether you start counting, your number in your head in between, or whether you count it when the exhale starts. It doesn't matter. The whole thing counts as 1. So if we have any part of it, it counts. Good? All right, go ahead. So respirations are always counted over 1 minute. So 12 to 20 is our normal. That means a patient breathed 12 to 20 times in a minute. They're always reported over a minute. They're not always counted over a minute, though. Most of the time, go ahead. Most of the time, in most settings, we're only going to count for 15 seconds and multiply that by 4, like we learned with pulse. But this care plan tells us we can't do that. What does this care plan say? 1 full minute. Go ahead. So if the care plan doesn't specify, we can do that 15-second count, and then multiply that by 4. But if the care plan says 1 full minute, we're going to have to count for that 1 full minute. Don't take shortcuts. All right, so we're going to document the amount of times that patient breathed on the documentation form provided by the nurse, and we have to be accurate within 2 breaths. So remember I said normal is between 12 and 20? So let's say the evaluator got 16, because they're counting when you do. They got to figure out whether you're accurate. They're going to count the respirations as you count them. So let's say that evaluator got 16. If you got 14, 15, 16, 17, or 18, you are accurate. Guys, that's half of the normal range. That's a huge margin of error. Got it? This isn't about accuracy. This test is not about accuracy. None of the skills are about accuracy. It's about technique, not about accuracy. Go ahead. All right, page 48 talks to you a little bit about documentation principles. This is something you can read on your own. But basically, CNAs in most healthcare settings are not allowed to document in words. That's because all medical documentation is a legal form. It can be called into a court case. And if you document in words, you could accidentally document words that the hospital or the healthcare setting that you're in becomes liable for. So most CNAs don't document in words. You document in numbers, respirations, pulse, feeding percentage. You might actually have, a checkoff list, bathing, dressing, grooming, but very few places are going to allow you to document with words. Now, if you go to work at a place that lets you write words in the medical chart, they have to do a training with you on what words to use and how to use them legally. Some of that will include being brief, being accurate, being complete, but not being overly wordy. The word I should never appear in medical documentation. You never want to say, I found the patient on the floor. Who is the focus on when I use that statement? I found the patient on the floor. That's right. Who's the focus supposed to be on? The patient. A lawyer will have a field day with that. So it would be not, I found the patient on the floor. It would be the patient was found on the floor. Who is the focus on then? The patient. So you have to have training in how to document with words. Does that make sense? If you make an error, even with numbers, you have to know what to do with the error. We don't erase, we don't use whiteout, and we don't scribble things out. We draw a single line through it. We write error above it with our initials and then document what should have been documented. Never obscure anything on a legal form. If it's obscured in any way, they automatically assume you're guilty of something and trying to cover it up. Good? All right, go ahead. Remember, this care plan is for this dude, not anybody else. We're going to count our respirations for 1 full minute on this guy. All right, so the video that I'm going to show you is one of the new ones. You'll see the checkpoints at the bottom of the screen, but you can also follow along with the breathing. As you're watching this video, you're going to see the writing on the bottom of the screen get bigger and get smaller. So it gets bigger as he inhales, it gets smaller as he exhales. If you count those, you'll actually count the breathing along with me. Now, for the test, you can use an alcohol pad on their chest to make the visualization of the chest rise easier. You're allowed to use that for the test. So an alcohol pad on top of the 3-drawer cabinet, just lay it on the patient's abdomen, upper tummy, or on their chest. And as their body expands for breathing in, it'll move that alcohol pad, makes it much easier to see. So you're allowed to use that. And you'll see that being used in this video. All right, Jake, go ahead and play the video.
Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Are you able to follow along with the breathing? Did you get the same result I did on the screen? That's fine. Remember, you can be off by 2 in either direction and still be okay. Still be accurate. Hey, Jake, can I get a packet, please? All right, so we're going to shift gears completely now. We're going to talk about the test registration process. So I want you to remember this. Class 4. The last hour of Class 4 is on test registration. You'll want to go back and review this sometime this weekend, I'm sure. All right, I have detailed registrations for you on our main website. If you go to 4YourCNA.com, look under the testing menu. I have a whole page on test registration instructions, which is what we're going over now. So that's your resource if you have any questions. Go ahead, Jake. This page, which is the front of your packet, this page is our roadmap. Tells us how we're going to get this whole process done and the approximate timeline that it's going to take. So step 1, if you look down here, the column, this is step 1, step 2, step 3, and step 4. Step 1 is all about the background check. Now, some of you guys are going to tell me I have a background check, and that's fantastic. I have no idea whether it's going to work or not. You have no idea whether it's going to work or not. You can try, but there's no one to call and nowhere to go to find out if it's going to work. This is a leap of faith. And if the background check does not work, it's going to delay the whole application process. Keep that in mind. Doesn't mean you can't use it. It just means that if it doesn't work, you're going to be about a week or 2 behind everybody else.
Okay, good. All right. So everything that I'm going to talk to you about is going to be located on Prometric's website. So this is the website. You might want to write this down on the front of this. I have in the first column, no, in the second column, I have the website. This is the newest version of that website. It's prometric.com/exams/nurse aid with an E -FL for Florida. So anybody that is joining us virtually, if you're New York, it's going to be -NY. If you're Texas, it would be -TX and so on. So they've streamlined all of their links to make it a little bit easier. On this page, Prometric's website for Florida, on this page, you're going to see that there's going to be some contact information at the front, which you at the top, which you can't see right here. And then you're going to see these what we call accordions, drop-down boxes. There's application process, candidate resources, training program resources, CNA registry, and important changes. These two are where you're going to need access to. These two. So the first one is the application process. Go ahead, Jake. Application process, if you open it, it opens up in an accordion, and you'll see right here, there's two links, one for the online and one for the paper. The paper is the one that I just handed out to all of you. You have the paper one. The online is exactly the same except for two small details, which we'll go into as we go through the process. There's two things that are different on the online versus the paper. This tells you the timeline. This tells you how this whole process works. But I'm going to go through it. I think a picture really is worth 1,000 words. So I'm going to show you this process in a little bit more user-friendly manner. Go ahead, Jake. All right. So when you are registering for the test, there's two steps. We have to have a background check and we have to have an application. So this is you. We have to have a background check and an application. And it really should be done in this order. Background check first, then application. Go ahead. Let me show you what's going to happen. I know this looks complex. I'm going to lead you through it. I'm going to show you what's going to happen with this process. When you, can I move this? No, it's locked. When you apply or when you get your background check, it goes to a very specific filing cabinet with the state of Florida. They don't give you anything. You don't submit anything. You just go to your appointment and they take care of it from there. They send that background check to a very specific filing cabinet called the clearinghouse. That's all you got to do for your background check. Just register for the appointment, go get your background check. They take care of it from there. So when you get your background check into the clearinghouse, then you can fill out your application. So you apply with Prometric either by mailing in this paper application or by filling out the online one, which does speed things up a little bit. Online is faster. When you apply with Prometric, they go to the clearinghouse, to that filing cabinet, and pull your application. They put that application with your, or they put that background check with your application, and it creates what we call a packet. That packet is then sent to the Board of Nursing. So let's just say for a second that you work, you've had a background check, you think you're covered, you don't do your background check, you just apply for the test. When Prometric looks in the clearinghouse and does not find your background check there, they don't have access to any other filing cabinets. This is it. This is the only one they can get into. If you're not in there, they have to contact you and say, hey, you're not in here. You've got to get a background check done. So you've got to make your appointment, go get the background check. They've got to wait for it to show up in the clearinghouse. And then you got to wait for Prometric to go back to that clearinghouse and see if it's there. Do you see how that might take a little bit more time? So if you've got one you think it'll work, that's fine. Just bear in mind, if it's not in the right filing cabinet, it will delay your testing. So once they get both your background check and your application, they put it together into a packet. It goes to the Board of Nursing. Now, what happens from that point? Go ahead, Jake. Prometric, once they send your application to the Board of Nursing, Prometric has nothing more to do with that application. It's now in the Board of Nursing's hand. And this can take some time because this is not an automated process. A live human at the Board of Nursing has to look at your background and your application and make sure that it's the same person. They have to make sure that you are of good moral character, that you're not going to steal grandma's candlesticks or bonk her over the head with them. They want to make sure that you are safe to go into grandma's home unsupervised and care for her. You have good moral conduct. Now, that doesn't mean that you have to go to work in home care, but that is the least restrictive environment, the one where you're going to have the most latitude, and they want to make sure that if you choose to go into home care, you're not going to steal grandma's candlesticks. They're going to look. Now, a question I get asked a lot through this program is, yeah, I got in trouble and I have a little charge on my background. Is that going to hurt me? The answer is maybe. They look at everything on a case-by-case basis. And one of the things that they're going to look at is the severity of the charge. How severe was it? Second thing they're going to look at is how long ago it was. The third thing they're going to look at is, did you complete whatever it is you needed to complete as penance for that crime? And then the next thing they're going to look at is, have you been cleaned since? So let me give you an example. We were all young and dumb. Not everybody got caught, but we were all young and dumb, made some questionable decisions. So let's say that you were young and dumb and got a DUI 9 years ago. It's pretty serious. But it was 9 years ago. You did your community service, you paid your fine, you went to the classes, you're in good shape now. And there's been nothing since then. The Board of Nursing looks at that and says, yep, young and dumb, but they learned. Now, if you've got 6 DUIs, the last one was 4 months ago, the Board of Nursing is going to look at that completely different, because 6 DUIs is showing a pattern. It's showing a substance abuse problem. Do you think I can let you around grandma's medication if you've got a substance abuse problem?
No.
No. Last one was 4 months ago. This means it's an ongoing problem. You haven't kicked it. So DUI, for both of them, 2 totally different situations. And that's why a computer can't do this. It's got to be a human. But just because this person has 6 DUIs, the last one 4 months ago, doesn't mean that they're automatically going to be kicked out and told, no, you can't test. What's going to happen is when the Board of Nursing takes a look at that, they're going to go, maybe there's a reason. Maybe there's a story here. And they will invite that person to come to a Board of Nursing meeting and tell their side of the story. They're going to ask you to submit something in writing. Tell me your side. They're going to ask for all the court records. They're going to try to be as fair as possible. And if you manage to convince them, they will probably allow you to test. If they don't allow you to test, they will give you a pathway, actionable steps that you can take, and tell you when you should look at reapplying. It's not a punitive process. Does that make sense? Okay.
Not against that. I just noticed on the bottom it says you have to put in as a challenger as a test option. So with me, I had taken my CNA test.
We're going to talk about your situation in just a minute.
Like, I'm required to have like a training on it to test again, is what I was told.
How long ago?
over 2 years. But
Then
one of the
it-
stipulations that they had physically told me when I spoke to the Board of Nursing was that I needed to take a specific like course.
That's the 120-hour program. And if it's been over 2 years, that does not, there's no, whoever you talk to on the phone may not have been familiar with the rule or understands the time lapse. Okay. Remember that the people that you're talking to on the phone are phone customer service agents. They may not be familiar with all the nuances.
And I
Okay.
know that's what they like drilled out. Like, you had to take a test and course. And I'm seeing this, I was like, oh no, like I need training apparently.
So if it's been 2 years since your last attempt, it's been over 2 years since your last attempt, you qualify as challenger again. The whole clock resets. So you now have 3 more chances to redo it again. Yep. If you want to test before that 2-year clock is up, then you have to take the 120-hour program. So here's something that most people don't understand, and I'm going to get into a little bit of politics here. The Board of Nursing does not like challenging the challenger option. They want to get rid of it. They've been trying to get rid of it for 10 years, and I'm actually in favor of getting rid of it. I don't like the challenger option either, because there's a lot of very unscrupulous test preps out there that take your money, don't train you, and it's not a good situation. And then the people that do get lucky and pass the test, they're not well trained. And grandma's the one that's going to suffer for that. I don't like test preps either. I get it. I understand their battle. The problem is that they aren't the only ones that get to write the rules. Florida's long-term care industry is huge. Billions of dollars in revenue. They pull a lot of weight. And the long-term care industry says, hey, hold up. We have to have employees. If you make education mandatory education is always expensive. So you guys all pay $370 to sit in these seats. Would you still be in these seats if this course was $1,200? Long-term care knows this. So right now they have access to 15 potential employees that can afford this class. You make this class mandatory and expensive. We now don't have 15. We might have 1. And how in the world are we going to staff our facilities if there's no students? So the Board of Nursing and the Florida Healthcare Association are at odds on this. They don't see eye to eye. So when you call the Board of Nursing and you're trying to get information, sure, they want you to go to a 120-hour program. They don't want you to challenge, right? Because they want to ensure that the people that are out there have quality. And I get it. I'm with them. I absolutely 100% agree, but I also understand the logistical side of things. Make sense? Okay. So the customer service agents may not have the full picture.
I was just under the impression that I was required to. So then when I read that, I was like, did I just pay for this and I still have to do something?
As long as it's been more than 2 years, and you can actually dig into the state statutes to find that. So if you're at all unsure, look at the state statutes. It's chapter 64, part 2 goes over you just Uncle Google Florida state statutes, chapter 64, part 2, and it'll bring it all up and you can read through it. All right. So the Board of Nursing reviews your application package, says, yes, you're good to go. That authorization goes back to Prometric. Prometric says, yay, we got here, right? You're able to test. That's awesome. They're going to send you a letter that says you've been approved. Now, from there, you got your approval letter. That's great. But from there, it's going to take a few days for Prometric to actually schedule your test, because they have to look at the testing center that you are going to tell them you want to test at a little bit later today. We're going to pick our testing center. You say you want to test at this testing center, so they've got to get a hold of that testing center and say, hey, what you got? What kind of openings do we have here? And it's going to pick one of those openings. You don't get to pick. You don't even get to give choices. It's going to pick the first available date, and it's going to slide you into that slot, and then they are going to notify you of your test date. So you did your background check, you filled out your application, it went to Prometric. Prometric put all the packet together, sent it to the Board of Nursing. Board of Nursing says, yes, you can test. When Board of Nursing says, yes, you can test, it goes back to Prometric. Prometric sends you an email saying you're approved, coordinates with the testing center. They work out a date. Prometric then tells you what that date is. If that date does not work, you call up Prometric, that date doesn't work. Do not tell them why. That date does not work. Simple. Don't go into detail. That date does not work. While they're on the phone with you, they will come up with a mutually agreeable date. And that's when you will test.
When have the VR signed up for me?
So for you, you'll take that whole packet to VR, and they will, there's a payment page in there at the very end. They will fill that out and they will send it in.
Okay, so I would send this page to this
That whole packet to VR.
to email to the VR.
You're not going to email it. You're going to have to take it to them because we're going to fill it out together.
Oh, okay.
Okay. All right. So everybody understand this? You don't get to pick your test date. On test day, you're going to have to go to the testing center. Your form is going to tell you to be there by, or that your test starts at 9. You need to be there no later than 8:30. If you are there at 8:31, they will turn you away. My suggestion, get there at 8. Get there at 8 because they've got to check everybody in. All right. Jake, go ahead. All right, so let's talk about that background check. So there's a couple different places that you can go get a background check. In December, I had a class that, this is expensive, guys. It's like $76. I get it. My class in December said, hey, we can get it done at the sheriff's office. So they went to the sheriff's office. And I told them at the time, I said, yeah, I know that other students have tried the sheriff's office and it never really worked out for them. And they said, no, they told me that it does work. They've got everything is good now. It works. I called the sheriff's office, said, do you do pre-testing, pre-certification background checks? I said, yes. My students all went. The delay, some of them were just testing in February. The delay, I mean, I had people that took my class in January that tested before them. The delay was pretty big. Now, they did save a couple bucks, absolutely. And that may be important for some of you. If you're going to pay one way or another, time or money. Figure out which one's worth more. Okay. So if money is more important to you, if you can't afford it, then maybe the sheriff's department might be a good option. But remember that it may actually take longer. All right. So this is one I know is very quick. This is DTIS. You've got right here on this page, separate paper, are the instructions for DTIS. This came directly from this site. I contacted them and I said, please give me step-by-step instructions that I can give to my students. So this paper came directly from them. But this is what the site will look like. I'm going to take you through this process really quickly. When you see this site, you're going to click on one of those two circled areas, and it's going to bring you to this page. You want to create an account. So you're going to click on new individuals and create an account. Go ahead. When you create an account, you got to put in your email and you got to select a password. And it's got to be one of those super crazy, big, long passwords with symbols and numbers and all that other stuff. And then it'll send you an email confirmation and everything. Go ahead. And then we're going to follow all of these steps. The big thing to know is that you have to have an ORI number. On this sheet, in the first column, highlighted is your ORI number, EDOH0380Z. This is the number you need, and it doesn't matter whether you go to the sheriff's office or Deontis or anywhere else, you need that ORI number. This is where this number tells them to put this background check in the clearinghouse, that filing cabinet. If you don't have that number right, it's going to go to a totally different filing cabinet. That's not going to help us. Go ahead. All right. So now that we've got our background check done, we have to apply for the test. So there's two ways of doing it. We can apply online or we can apply through the paper application I just handed out. This is the address you send that paper application to. Right here on Prometric's website, it gives you their contact information. Down below that, it's got this disclaimer that's super important. We're going to read this together. It says, if it has been more than 5 business days since you submitted an application and you have not received confirmation, please reach us by phone or email. So when you apply for the test and it's been 5 days and you haven't gotten anything back from Prometric, nothing, crickets, no emails, you need to call them. And you need your Prometric number when you call, which you'll get when you apply. You need to call them. The problem is that sometimes application, this is a lot of wheels here, guys. Applications can get lost. The system might glitch out. Your internet connection could drop. I mean, there's a lot of variables here. So when they get your application and they process it, you're going to get an email that says that the application is complete. They got it. They processed it. It's all there. It's all together. They're sending it to the Board of Nursing. Good job. If you don't get anything from them, that means that something happened somewhere in there and your application is stalled. It's stopped. So this is how you contact them. It's got their phone number and their email right there. That's where you find it. Go ahead. All right, so 2 ways of registering: paper application and online application. Online is faster. I'll tell you the differences between the two when we get to that point. Go ahead. So if we go to the actual application here, which is the page in your packet that has a number 1 at the bottom. Page in the packet that has a number 1 at the bottom. It looks like this. This is the paper application. Couple things that we need to pay attention to. Go ahead. Is it has a stop sign. That stop sign says, hey guys, please make sure your name is your name. The name you put on this application has to match the 2 forms of ID that you're using to verify your identity. Anybody in here have more than 3 names? Do I have anybody in here with more than 3 names? Okay, that's when it gets really complex. Some people have 4 names. Sometimes they're hyphenated, sometimes they're not. And that really makes this a little more complex. Whatever is on your ID is what you're going to put on here for your name. The exception to that is that this form is only asking for the first initial of your middle name, not the whole thing. Your ID probably has your whole middle name spelled out. That's okay. All right. Below that, it's going to ask you, go ahead, Jake. It's going to ask you if you need ADA accommodations. This is Americans with Disabilities Act. Do you need a seeing eye dog? Do you need a sign language interpreter? That type of thing. If you do, there's a whole packet you have to fill out. I'm sorry, there's a whole packet you have to print and your physician has to fill out and you have to submit it. Next section is candidate information. Now, we're not going to fill this out together in class. Go ahead, Jake. We're not going to fill this out together in class. You can fill out your demographic information on your own. We're going to kind of skip through this, go to the next one, and skip through the next section as well. You're going to fill that out on your own. Let's go down here, go ahead, to the criminal and Medicaid, Medicare fraud questions. If you have a felony in your background, you need to see me after class. Anybody with a felony needs to see me after class. If you have no felonies in your background, You probably want to keep up with me. This is the part you do want to fill out in class so we know what we're doing here. For number 1, put no. Leave A, B, C, D, and E blank. Do not answer those. Do not put anything in those boxes. If you have no felonies for number 1, put no. We're on the page with a 2 on the bottom. We're on the page with a 2 on the bottom. If you have no felonies for number 1, check no. Number 1 is all about felonies. If you have none, it doesn't apply to you. Go down to the bottom of the page. For number 2, check no. Again, if you have no felonies, 2 does not apply to you. Right there. Yep, for 2, check no. There you go. All right, turn the page. Jake, go ahead. For number 3, 4, and 5, I need to explain to you what this is because the wording is a little vague. For number 3, 4, and 5, if you have ever worked for a healthcare professional that was caught committing Medicare or Medicaid fraud, and you were prosecuted as well for being involved in that crime, these 3 questions would apply to you. If you have never been involved in Medicare or Medicaid fraud from a provider standpoint, from a medical professional standpoint, you would answer no to 3, 4, and 5. We have 3 that I know of, physicians in our community, that were convicted of Medicare and Medicaid fraud. So this is a relevant question. Okay. But in order for them to take action against you, you would have had to go to court. They would have served you papers. You would have had to stand in front of a judge, and they would have declared that you cannot work in healthcare anymore. So you would know this is a situation you would know happened to you. Okay, go ahead. Next section is disciplinary history. What they want to make sure is you weren't a CNA in Indiana, knocked around some old people, got your license taken away, and now you want to come to Florida and do it here. That's what they're looking for. They're asking if you have had any disciplinary actions taken against you as a medical professional. If you've never been a medical professional, the answer is no. I used to rush through this, but I actually had an occupational therapy therapist that happened to. She had her occupational therapy license taken away from her in another state. She came to Florida and thought she'd be a CNA. So I used to rush through this, but I can't rush through it because I don't know your backgrounds, guys. I have no idea where you're coming to me from. So if you've ever been a medical professional, you need to read these and answer them. If you've never been a medical professional, the answer is no. Let's go down to criminal history. First question is, do you have one? There's only 2 choices here, yes and no. Choose one. If the answer is, well, maybe, it's probably yes. The next question is asked if you've ever had any records sealed, which means that you have a criminal history, but you paid a lawyer $5,000 to make it disappear. It didn't. We're still going to find it. And they want to see how honest you are. You're going to check that box. Next question is juvie. So the last question is, have you ever been adjudicated delinquent? So that means that you had a juvenile record that they decided wasn't going to count against you. Everything, when it comes to healthcare, everything is going to come up. Everything. I don't care how hidden you think it is, it will come up.
Those things never go away.
And the reason is we're saying that you're safe to go into grandma's house unsupervised, and we got to know what kind of person you are. So I don't care what the lawyer promised you, we're gonna find it, period. So it's much better to check yes on this box and have them look and find nothing. No problem. Again, they look at everything on a case-by-case basis. So they don't decline you right out of hand. They don't say, nope, you're no good. We're not going to even talk to you. That doesn't work like that. They're going to contact you and they're going to say, hey, tell us your side of the story. Send us the court records. Whatever you got, send it to us. And they want to know your side of the story. And then if there's a question, they will ask you to come to the board of nursing and talk to them. But they're looking at how long it was, how serious the offense was, how long ago it was. Did you complete all of the requirements to, clear your name? And how many offenses have you had since then? One small charge as a juvenile 8 years ago, and you've been clean ever since, it's not going to count against you. Now, the exception to that is if you committed vehicular manslaughter and then ran from the cops, and that was 8 years ago, then they might look at that a little bit different, right? So they look at the severity of the case. Okay. But they always, they don't just dismiss you out of hand. They'll always give you an opportunity to tell your side of the story. So again, it would be best to check yes here and have nothing show up. If you check yes in this box and nothing comes up, they know that it was a juvenile offense that wasn't ever held against you. It wasn't prosecuted. There was pretrial intervention. You may have had to go to kid court. You may have, and they told you that if you do this, it won't go on your record and all of that. That's fine. The Board of Nursing is going to say, hey, they're honest. But if you check no here and you had a vehicular manslaughter when you were 17 and you went through pretrial intervention, PTI, and you did your service and they told you at 18 this will drop off, it did not. It did not. Now you have lied on this application. Do you think they're going to be lenient?
No, they're probably going to trash.
So if you have anything, declare it. If it doesn't show up, that's good. You're honest. Okay, good? Good. Okay, go ahead. Okay, at the top of page 4, we're on page 4 now. Go to page 4. At the top of page 4 is something called a health history. I cannot legally help you with this page. I am not allowed to help you. Nobody can help you. These are self-declarations. But I need you to understand that healthcare is stressful. It's a stressful environment. And they're trying to make sure that you are somewhat well-adjusted and able to work under stress and that you don't have substance abuse problems and things like that. Because working in a stressful environment with no coping mechanisms, that's a recipe for disaster. So you're going to answer these questions and indicate your Social Security number at the bottom. Go to page 5. One more. All right, at the top of page 5, it's going to ask us for our eligibility. I want to remind you, this is what you were talking about earlier. At the very bottom of this page, it says you must select E3 Challenger. So for most of you, not all, but most of you, you're going to select E3 Challenger. I've already done that for you on this page. You'll see it's already checked off. If you are a lapsed nursing assistant, so you were a CNA, it expired, you're now trying to get it back, you would want to check off E5. Okay. There's really no need for any others. E3 or E5. Good? Okay, go ahead, Jake. I've already checked off E3 on this form that I gave you because when you get home, you're going to forget 90% of what I just said. And you're probably going to start checking off things that you don't need to be checking off. If you check off E1 or E2 here, this is not a 120-hour program with clinicals. When you check off E1 or E2, they're going to need a letter from the school that gave you the 120-hour program with clinicals. There isn't one. And that's a problem because you're telling them that you went to a program that doesn't exist. And they're not going to be able, it'll delay your testing. So I need you to check, I know you're sitting in a classroom, but this is test prep. I need you to check E3.
What if you did take a course, but it was like 8 years ago?
It doesn't count. Doesn't count. You have to test within 6 calendar months of completing a 120-hour program for it to count under one of those two. Yeah, so it wouldn't count. All right, so the next section here, training information, I put a big X through because we only fill that out if we selected E1 or E2. What did we check? Doesn't apply to us. That's why I put a big X there for you. We go down to test site information. You are going to check off, or I've already checked off for you, regional test site. We're all going to test the regional. We don't do emphasis. They don't come here to test. We're not set up for them to test here 7 days a week. Not set up for it. Our closest testing center is in Tampa. So we have to actually tell them where we want to test. This box right here is going to tell them where we want to test. So go back to the beginning of our packet. And these two pages are all the testing centers in Florida. These 2 pages. These are available on Prometric's website as well. But theirs don't make any sense the way they have them organized. I organize them for you by region. So you can quickly figure out we're in the Central Florida region. You can see which ones are available to you. If you live in Citrus County, Ocala might be a better option. Tampa, Agilus, and the very last one on this page, the very last one, this is the closest one geographically to us, Agilus. That's the one I recommend. There's 2 others in Tampa. There's one over by USF, Busch Gardens area, and then there's one way over in Temple Terrace. If you want to go to Busch Gardens, then pick one of those. I don't know. But there's also, there's others. If you want to go to Miami and test, go to Miami. There's Jacksonville. There's Tallahassee. You can test anywhere. Pick one that you want to go to. But next to the name is a code. You can see the code there. Very important, guys. Very important. If you go online to fill out the online application, it's exactly the same. You just take what you put in this paper application and put it in the online one. Exactly the same, except for this. In the paper application, you have to put the code. See the code in front of the name? That code? You have to put that code in the box. Online, it's a drop-down menu. You would just select the name that the name of the testing area you want to go to. Go ahead, Jake. Okay, so we're going to put our code in this box. If you're doing online, it's a drop-down box. All right, so now let's get to our test. There's lots of options. Lots of options. Most of you are going to need the first one. Just the plain test. Normal test. The skills and the written. No frills. Both of them in English. If any of you speak Spanish as your first language, you might want the written test in Spanish. And you can see there's an option for it down here. Written test in Spanish. There's also an oral component, which means that the computer reads the test question and answer choices to you. This is good if English is not your first language, or if you have a reading disability or a processing disability. You can choose audio, which means the computer will read the test question to you. Audio is available in English and Spanish. So you get to choose the kind of test you want to take. First one is the plain Jane test. The second one is English test with audio. Down here is written test in Spanish, and then written test in Spanish with audio in Spanish. So choose one of those four. Most of you will choose the first one. Go ahead, Jake. Go ahead. Go ahead. Okay, the other options here are for retakes. That doesn't apply to us. We're taking both sections. But if you have to repeat the test, you're only going to have to retake the portion that you failed. So if you pass the written and failed the skills, you only have to retake the skills. And that's what these two sections are all about. Okay, skills are always done in English. Cost for the test is $155 no matter what option you chose. Same cost, $155. And you have to pay that when you register. You're paying that to Prometric, not to me. It doesn't come to me. You can pay it online when you do the online application, or the last page of this application will have a payment area that you can write in your payment method. Okay, go ahead. Page 6, at the top is a box regarding your electronic fingerprints. You know how everybody has to give you a privacy policy now, right? So the very last page of this, that is the privacy policy. When you check yes on that box, it says that you've read this privacy policy. I don't care if you read it, you've got it. So you can check the box. Okay. Good. And then below it, that's your, go back up one, I'm sorry. Below it, that's your attestation. Just says that you are you. You know, you understand the process, you understand what you're doing. You're going to sign and date there. Go ahead. Now, at the very bottom of that form, it says that if you do not receive your emailed authorization to test letter in 10 to 14 business days, you need to contact them. Now, this is business days, not calendar days, business days. So roughly 3 calendar weeks from the time that you apply until you get your test date is what they're telling you is the norm. About 3 calendar weeks, 10 to 14 business days, which comes out to be about 3 calendar weeks. If you do not have your test date within 3 calendar weeks, you need to contact them. Okay. Good? Go ahead. All right. So when you get your emails back from Prometric, the email itself is very generic. You have to click on the attachment to open it. And the attachment will have your specific information on it. And the first one you get, you want to make sure that in the little boxes, it says application status complete. If it says incomplete, they're missing something. They're missing your background check. They're missing your payment. They're missing something. If it says complete, at the bottom, it'll say pending approval. What that means is they got everything they needed. They send it to the Board of Nursing. We're waiting. Pending approval. The next email you get, you'll open the attachment, and that pending approval will change to approved. Means it went to the Board of Nursing. They said yes, sent it back to us. We're good. We're going to schedule your test. Hold on. The third email you get, open the attachment, will be your test date. Make sure you're checking your spam folders, especially if you have a Yahoo or iCloud email address. Yahoo and iCloud filter everything. So most of the time, these notices will go into your spam or promotions folder. Go ahead. Remember that this is how you contact Prometric and when you should contact them if you don't hear from them. Go ahead. Go ahead. Okay. All right. Any questions on test registration process?
So that means I have to do my background check first, and then I can send this paper to the VR's office.
Right.
Snapping sign.
And you'll
Okay.
probably need to go to VR to schedule your background check. They'll help you with that too.
Okay, so I can contact the VR and please schedule my background check.
Right.
before
And
the
take
meeting.
that front paper. Yep. Take that one with you because that tells them how to help you with your background check.
Or I can go to a sheriff's department too with the background check too, right?
Right. But you still have to pay for it.
Okay.
Still have to pay for it. So if VR is covering it, contact your caseworker.
Okay.
And they can always contact us for more information. So there's one more thing about the online application I need to tell you guys about. If you decide to do the online application, it is much, much, much quicker. I recommend the online application. I told you that there's a drop-down box to select your testing facility. Remember that? There's one more change in the online that is not on this paper. At the very bottom of the online application is going to be a box asking how you plan on submitting supporting information. And there's going to be two options there, by fax or by mail. That's what it is, by fax or by mail. You have to check a box. I don't care what you check. Nobody cares what you check. Check a box. And what that is saying is, if we contact you and ask you for more information, if you have a background that I need more information on, if you have an immigration thing that I need more information on, if your background check doesn't match your application and I need to get in touch, how are you going to send me documents? That is what this is. You have to choose one, by mail or by fax. I don't care which one you check, but if you don't check a box there, your application will not submit, and it's not going to tell you it didn't submit. At the very bottom of the online application is going to be save and submit. If you save, it erases all of your payment information. So you have to put all of that in again before you can submit. I recommend saving. Fill out the complete application, save it, then put your payment information in and hit submit. Okay. So those are the differences between the paper application and the online. Questions? All right. So you have 2 chapters of homework tonight, chapters 5 and 6. You're going to read them in the yellow book. Do the tests in the white book on page 185 and 186, and then make sure that you grade those tests as well.
So what is the deadline for registration to be done?
There is no deadline. There's no.
So you pick the dates to register the test.
Sooner the better.
Yeah. If you remember, the whole thing should take about 3 weeks, right?
Yeah.
So if you register this weekend, you should get your test date about a week after graduation, which is perfect timing.
Okay.
If you wait 3 weeks to register, it's going to take a whole lot longer to test, and you may forget a lot of what we've talked about in class. You've got all these resources to review, but sooner is better.
Okay.
On the fingerprints, the background check and all that, can we go to the UPS or UPS place? That's where I went.
You can. That's where Deontis is going to send you.
Oh, okay. Okay.
If you register online through this paper, right? If you follow these directions and register, it's cheaper. If you just walk in, they charge you $20 more.
Hold on. Sorry, guys, real quick. Can grab a water.
Sure.
I do have a private question.
Let me go ahead and sign off.
Okay.
All right. Those of you who joined us virtually, thank you so much for sticking around. We'll be back in class on Monday. Remember, Tuesday is the game show that will help you prepare for the test as well. Until next time, have a great weekend. Happy caregiving. Bye.
Just on this.